Okay. There we go. From current slide. All right. So here's how I would approach this material. So, I look at this, I don't see a question on your exam from this slide, okay? But this is just setting the stage for what you do need to know, okay? The idea is you have to know the basic idea that the way viral infections work, okay? I don't want to just read off the slide because that'll be a waste of time for you guys. But the whole idea of the cell being hijacked, all right, making more viruses, proliferating and causing an inflammatory response is what you need to have in mind as we approach more of this information, okay? All right. So you need to make sure that when you look at this information, you group it. All right. When I say grouping, I mean that there are going to be some pathology slides that are going to be based on knowing that it's an abscess or knowing that it's pneumonia or knowing that it's, whatever. I want you guys to realize that, like, okay, there's going to be granulomas. So whenever we come up to that, you're going to see like tuberculosis. She's just setting the stage here. So, let's just kind of get to the cool. She's just trying to make sure you understand this information. So far, based on my experience, you're not getting a specific question, okay? Also, bear in mind, everybody, okay, that you may get questions in the exam where you can't even tell who wrote the question because the material really overlaps, okay? You're going to see as we approach Dr. Weaver's lecture, we look at Dr. Yant's, and we look at some of the other professors, they go over the same material, okay? And they may test it in different ways, but it's the same information, okay? So anyway, okay, be aware of this slide, guys. Be aware of this picture. This picture could show up on your exam, all right? It's the whole idea. It's, don't make it, it's not rocket science. You can see literally the pneumonia right here, okay? Don't make this harder than it has to be on yourself, all right? Now that I see the red lung, we're going to get into the hepatization crap, all right? The congestion and red hepatization. This is 100% a question on your exam. No question about it whatsoever, okay? Now, how would she test this, all right? The way she would test it is that she's going to want to know if you know what the histology is like in each section, all right? So let's look at some of the highlights of each of these, all right? The whole vascular engorgement, intraalveolar fluid, few neutrophils, and bacteria. All right, congestion is not actually a big important thing when it comes to the histology. That one is just based on it being heavy and boggy and red, all right? Especially being boggy, all right? Congested. Red hepatization, please, please, please be careful, be very, very mindful of the fact that there's red cells and neutrophils, all right? Like that's the hallmark of red hepatization, all right? You need to know the order as well, okay? Look at gray hepatization. That's where you start getting fibrosis, okay? The fibrinopurulent exudate, okay? That's where some of the fibrosis begins, all right? So what is the idea of gray hepatization? I think of fibrosis. It's firm and a grayish brown. Like that's my summary of gray hepatization, okay? Red hepatization, I'm thinking of literally acute inflammation at this point. Red hepatization, I get neutrophils and I get red cells, okay? Some fibrin, but ignore that for now, all right? The hallmark is red cells and neutrophils. When I look at resolution, the hallmark is that macrophages are coming in and they're eating up all of the debris that was set up by the neutrophils during the early stage, which was the red hepatization, right? Resolution is literally when the macrophages can come in and clean up, and whatever damage is done. But it's trying to take away all the excess stuff, the stuff that hasn't been the remodeling of the lung, okay? So I want to see everybody in the group chat. Do you guys understand the importance of this slide and knowing basically you have to know this, okay? Everyone put okay in the messages because I want to know you heard me and you understand what I said because it's a question on your exam, okay? I'd be very surprised if it wasn't. High yield for boards as well, okay? They'll literally be like, histology has fibrosis, no red cells. You're thinking of gray hepatization. If you see macrophages, resolution. If you see red blood cells and neutrophils, you're thinking of red hepatization. Exclusive, the one that's the diagnosis of exclusion, right? Congestion, okay? Few neutrophils and bacteria, mainly it's just fluid, okay? So know that. All right. Pictures wise, honestly, guys, I'm not even gonna act like I'm some like expert of all this stuff. Oh, let me make sure I point this out, guys. Nothing I say is anywhere in comparison to the amazingness of Pathoma. Okay, the way that Dr. Sitar explains this stuff, if you haven't watched it, I highly recommend that you do. Okay, I'm only recommending a lot of this stuff is because we're still at least a week before your exam. Okay, so there's no major panic going on right now. You can still manage the material and you can move forward very calmly, but I want you to make sure that you know the Pathoma on there because it really just gives you a really solid framework. Okay, I'm just putting that out there. Okay, so gray hepatization, find a way to like visualize that for yourself. Okay, a lot of this is visual, but it makes sense to me. Okay, bronchopneumonia, they're just right here. This is just getting you ready to be able to tell, remember how this is a regular lung, how there's nothing inside of the alveoli versus, oh my God, literally every second is consolidated. All right, not every second, every spot is consolidated. Okay, so anyway, now another picture with right hepatization. The way I would remember this is I do see the red cells and I do see the nuclear infiltrate. I do see those neutrophils that are coming in. Okay, to me, you have to find a way for yourself to make sense of this. Okay, I hated histology, but a lot of the stuff that Dr. Campbell does. By the way, does she still put almost the exact same slide on her exam that she did on her PowerPoint? Does she still do that? No, not anymore. Okay. That sucks. All right. 50% of the time okay. All right. Well, I guess that makes things a little bit more complicated, but I doubt she would pick for the most part something that is really, really out there compared to what you normally used to. Okay. So you need to kind of have a unique visualization of this picture. Okay. Like find the small details in it that make sense because it's very likely that if she tested hepatization, it could be through a picture. Okay. So like, let's look. Okay, is she done with hepatization stuff? Let me just double check. Don't worry, I'm not just cruising the stuff and not going over it. All right. So actually, a lot of the microbiology is going to be addressed way better later on, but the hallmark of strep pneumo is diplococci. Okay, you literally see two dots that are together. Okay, and I see that well throughout this entire area. Okay, I see it like literally. You see another one right there. So you need to get used to that. Very common, very, very, very common. Get used to it. Make it a reflex when you see it. All right. Intraocular exudate. It's not really that insanely important. Okay. Basically, look, guys, you need to be used to seeing pink telling you that that's fibrin. Okay. So if you see a bunch of pink everywhere, right? You see how this is a meshwork? I'm thinking more of the phase that's either fibrotic, which is gray hepatization is where you're fibrotic, but then after that you have macrophages that are literally, you've already had the fibrosis, but macrophages are coming in and they're cleaning up the area. All the debris and whatnot is being taken care of. So this picture wasn't high yield. But now I remember Dr. Campbell making a big deal about, guys, you should know the pictures of the different microbiologic agents. Okay. So the clusters of purple dots is always Staph aureus. The two diplococci is strep pneumo. Okay. And then there's this is the harder one, intracellular. The intracellular, what is it called? Intracellular rods being Klebsiella or E. coli or whatnot. That's less high yield. These are super high yield. You need to know these two pictures. You need to know that when you see these two dots, strep pneumo. You see a cluster of purple. Don't be like, oh my God, dude, look, like there's a circle there. There's a circle there. This could be a diplococci. No, don't do that to yourself. Look at what the majority, if you see a cluster, don't trick yourself. It's a cluster, okay? Notice how obvious the diplococci of strep pneumo is. I'm belaboring this because you need to know it, okay? You need to know it. You see how like I go over some slides and I'm just like, I go quickly? It's because I don't consider it to be too high yield, all right? She's giving you more definitions of the whole empyema, bacterial dissemination. Like, don't worry right now about that. Okay. for the rest of this entire block, the most common of everything is strep pneumo. Okay? Just think that way. For now, just think that way. Most common cause of pneumonia, whatever you're thinking. Look, guys, Complex will literally throw like 8 strep pneumo questions at you. Okay? And you'll be like, wow, dude, is it really possible that they're doing this? Yes, because it's so common. Okay? They just literally like to see that you know it cold. Okay? Lancet shaped, gram-positive diplococci. All right? Strep pneumo, done. Don't make it harder on yourself. All right? Haemophilus is like the secondary one that we think of. Like if you're going to think of anything after that, you're going to think of Haemophilus. And they're saying is the most common cause of COPD exacerbation. Like that might be important to remember. If she gives you a patient with a heavy smoking history and is in respiratory distress, you know, it's possible that you can be thinking of Haemophilus, but I doubt she would do that to you. You need to be thinking of strep pneumo most of the time. Okay. If ever in doubt, pick strep pneumo. But I know that you have a lecture from Dr. Colley, and we'll go over that, but you need to know the basics, okay? Moraxilla catarrhalis, please don't memorize anything about it. It's rarely important. It's never the right answer on a question, okay? It's rare. It's literally like second most of something, third most of something. Don't memorize it, okay? Just know that it's second or third of something. If you don't see strep pneumo and you don't see Haemophilus, then maybe you'll think about Moraxilla. But it's almost never the right answer on any exam in medicine. Okay. So, Staph aureus, the first thing we think of, guys, you need to know this, is that if somebody recently had, you know, some sort of, you know, cold a week or two ago, and now they're coming in and they have, you know, a heavy fever and whatnot, it's Staph aureus, because it's basically the setup for a Staph aureus infection is a viral infection. Okay, so you get a viral infection, a few weeks later, you're coming in with fever and whatnot. That's a secondary bacterial infection. It's secondary to the viral illness. Okay, so look for that in the vignette. Okay, if you have a viral illness and then they're okay and they get an infection later on, it's probably not another viral infection. It's probably Staph aureus causing their pneumonia. Okay, and what do you think of when you say pneumonia? You're going to be thinking of them giving you an idea that, X-ray shows the middle lobe is consolidated, or it shows consolidation in the left lower field. Okay, that's just fancy words telling you this person has a lobar pneumonia. Okay, that doesn't help you. You have to know the rest of the history. Okay, if the person is an alcoholic, you think immediately of Klebsiella. Okay, screw strep pneumo at that point. You think of Klebsiella. Okay, they have consolidation in a lobe and they have a history of heavy drinking. You think of Klebsiella. Okay, or if they've had, you know, actually we're not going to add any more to that, but just think about it. People who are alcoholics, the reason they get Klebsiella is because they get altered mental status and they have impaired usage of their glottic reflex. Don't worry about all that. It was from last block, but glottic reflex was the whole, you know, it doesn't cover up the trachea, and so they get food that goes down that tube, and they basically get an anaerobic infection. Okay, but hallmark is what? Staph aureus, secondary bacterial infection after viral. Klebsiella, infection after somebody who has a history of alcohol. Okay, strep pneumo, I'm going to say it 5 billion times. Okay, I'm just giving you the nature of this block. It just is that way. Okay. We'll be getting more into Pseudomonas, but if you want to pick one thing from here, it's cystic fibrosis. All right. And ventilators. Cystic fibrosis and ventilators. Those are the two things that I think of when I think of Pseudomonas in a hospital. Okay. Yes, there are burns, neutropenia, but these are usually skin infections. Okay. I think of, when I talk about the respiratory tract, I'm thinking of ventilators and cystic fibrosis. All right. Legionella, artificial water environment, you know, I mean, that's just the way it is. Okay. You just have to memorize that. Okay. Somebody who comes in and guess what? They have bacteria and they have diarrhea. Okay. Makes sense. If it's due to the water environment that they drank or whatever, they're going to get diarrhea and they're going to get pneumonia, and it's a big deal. That's the highlight of most of the micro that's on your exam. Okay. Know that. Those are the buzzwords, the ideas, the vignettes that they give you. Those are what the things you need to, that's what you need to know. Okay. You're probably going to get I remember on our exam, we did get a question about a lung abscess. I'm pretty sure she has a picture of it later on. I'll go over it when I see it. You know, you don't need to memorize all this stuff. Make sense of it. This is where a concept comes in, guys. Okay. Whenever you have, why would cancer, for instance, cause a lung abscess? It's because the cancer is going to press on the airway, and you're just going to have obstruction. And so whenever there's obstruction, Dr. Satar always says this in pathoma, when you have obstruction, you can get infection. It is what it is. All right. You just have to know that. And people, basically the lung abscess happens when they have an infection for a long period of time and nothing gets done about it. Okay. So anyway, you can look at this list and pretty much anything can cause a lung abscess, but for the most part, that's what you need to know. Just kind of for the vignette, just know that almost anything can cause an abscess, and it's not going to be the way you're going to get the question right. Okay. Destruction of lung parenchyma. I'm pretty sure she has a picture that comes up. Guys, I mean, it's really not that tricky. You know, lung abscesses, they just, you know, like there's literal destruction of the lung parenchyma. There's a hole in their lung. Okay. I think we got a question on this on our exam. Okay. How do you get this right? You look and you literally don't even see the architecture of the lung anymore. Okay. You see this like disrupt, you see like a little bit of it, but there's inflammation. There's literal red cells and congestion in the areas that look like there is architecture, but for the most part, look like the alveoli are destroyed. It's just this big hole with inflammation in it. Okay. So don't miss this question. Okay. If you see architecture just absolutely disrupted, don't trick yourself. It's an abscess. All right. Look, this is the picture she put on our exam. Look, you see normal architecture here, but it's gone here. You don't see any normal architecture. Okay. That's the hallmark of a lung abscess. This is not going to be tested on your exam from here. Okay. It'll be tested from Dr. Colley if he wants to pick something like this. It'll be in his slide. Now, this is actually pretty dear to my heart because I just remember when I was tutoring respiratory when we were in the course 2 years ago, I literally can't believe it. I remember during the tutoring session, I was like, guys, get ready. You're going to get a question that tells the difference between interstitial pneumonia and alveolar pneumonia. Okay, what do I mean by that? Let me go ahead and draw. Can everyone see this red that I just drew? Put it okay in the group chat just so I know. Okay, great. So here's the structure. Let's say, look, I don't even know what I'm about to do in terms of draw. I didn't have a plan for how I was going to draw the alveoli, so I'm just going to try to illustrate my point the best that I can. All right, this is a horrible image, but you'll see what I mean. Alveoli are here, okay? This is the airway, all right? And then the septae, which is basically the interstitium, okay, is literally right here. Why am I drawing this? I'm drawing this to illustrate a point. If you get a question that has inflammation here, largely, it's not an atypical pneumonia. It's not interstitial pneumonia, okay? It's regular pneumonia. It's lobar pneumonia, okay? It's inside of the alveolar area. Interstitial pneumonia, you get the inflammation on literally in the septa, okay? So it looks like this, all right? We'll see a picture. I want you to get that idea, okay? I literally drew this for everybody during the tutoring session. And then when I got the question on my exam, I was literally careless and quick, and I missed the question. I was so salty. I was straight up so salty because it's such an easy question, but it humbled me, and it allows me to remember that, guys, approach each question carefully, okay? They can be easy, but you can miss them if you're not careful, okay? Doesn't matter what your background is. You can miss these easy questions, okay? So let's keep going and look at an actual good picture of what this looks like, all right? So the causative agent is mycoplasma. From now on, you see mycoplasma pneumonia, you're thinking of what? You're thinking of an atypical pneumonia, walking pneumonia. What does walking pneumonia mean? It's literally essentially a less aggressive pneumonia, okay? It means that these people are literally at home and they have this cough that won't go away. They might have a light fever, but they're functional, okay? But they have this really light, they basically have a light pneumonia, they do an x-ray and they see infiltrates in both sides that are diffuse and it's not lobar. Okay, that's what an atypical mycoplasma infection is. Okay, here they're just talking about the pathogenesis. Cool story. I mean, I don't see anything specific here, but remember, interstitial inflammation is the key word. Okay, so the alveolar septa are widened with edema and inflammatory cells, not the inside of the lung, not the alveoli, guys. Okay, intraalveolar proteinaceous material if you're going to have anything, but you're not going to have an intraalveolar, for the most part, infiltrate of cells, for the most part. Okay, you might have a little bit, but it's nothing in comparison to what you find in the septa. Okay, so let's look. Look, how obvious is this? Okay, like you can't miss it. You really can't miss it. All right, you still have the architecture preserved, so it's not an abscess. Okay, but you just have inflammation in the septa, not in the airways. Okay, yes, I see a few things right here, but guys, don't trick yourself. Like, don't do that to yourself. Just make histology as simple as possible for yourself. Interstitial pneumonia. Most likely causative agent is mycoplasma. Does everybody understand what I just said? Just put an okay or a yes. And I'm going to just put this out there real quick. I want everybody to know that, like, if you have a question, please post it. I'm sure everybody who's been in these sessions is sick of me saying that, but please post it. I guarantee you're not the only one. So don't be like, oh my God, I'm going to be that guy if I post this in the chat. No, please, I want to address it, okay? And if you still feel shy, please email me after or stay after and ask me the question. Privately message it to me in the Zoom group chat. Anyway, okay, this picture. If she wants to trick you, this is the hardest it would get. Here is the inside of the cell. This is just, look, you see purple? This is basically a cross-section of the lung, the bronchiole, okay? That purple diffuse stuff is just exudate, okay? Yes, there is some purple stuff, but look, it's nothing in comparison to what's inside of the interstitium, okay? This is the inside of the alveoli. This is the interstitium. Where's the inflammation? In the interstitium. It's in the interstitium, okay? Don't miss it, okay? Again, if you look at this picture, yes, you see some red in the inside, but for the most part, the alveoli are clean. You see purple infiltrate in the interstitium. Don't trick yourself. Look at where it is before you even care about what the causative agent is. Look at where it is. If it's in the spaces, look for diplococci. If they're not diplococci, it's not strep pneumo. Look for clusters, very obvious clusters of purple inside of the alveolar cells. If that's it, it's Staph aureus. If it's not, I guarantee you it's not going to go to Klebsiella at that point, okay? If you see alcohol in the vignette, then it's probably Klebsiella. Otherwise, interstitial, it's mycoplasma, okay? But yes, they're talking about how CMV can be atypical. We'll get to there. We'll get to that when we see it in the PowerPoint, okay? RSV infection, okay? Respiratory syncytial. Guys, you would just literally have to memorize the picture. I mean, I don't personally think this picture is necessarily high yield, but like I wouldn't even memorize RSV. I would memorize the other ones. And I mean, I guess it is sort of unique in a way, but it's not really, that's not like the strategic way I would go about it. But I mean, okay, round, pink, intracytoplasmic inclusions. Okay, RSV is in a kid. So she has to give you a histologic slide and tell you it's a kid. Very few of these are going to be in a kid, okay? A lot of these are adults, all right? Okay, I mean, she may have put this on the exam, the Cowdrey bodies, like, you know, you can just, I mean, a lot of it feels like it looks the same, but it really doesn't, okay? I encourage you, if you feel like this looks the same, when you go back over this PowerPoint, I encourage you to go to Google Images and look at multiple different examples, okay? Like I said, I can't learn this for you. You really have to kind of find your own way of, if it's obvious, I'll try to help you out. But other than that, it's just recognition, okay? Did she put this? Warthin-Finkeldy cells. Honestly, I can't remember which one she picked in this, okay? I'm sure she, it sounds like, it seems like this is an important slide. So I would learn this, okay? look up different pictures of Warthin Finkeldy. This is what I did when I was in your place. Okay, that's the way to approach histology. Okay, when it comes to specific things that she stresses, please look up different examples. Don't just like, oh, okay, cool slide, peace. No, you're gonna miss the question if you do that. Okay, so I mean, you can kind of compare and contrast, like HSV, like you just have this almost, usually you have like a halo. See this? This is probably the one she would put. She would put like the nucleus, and it would be like a halo around it. You can see it's almost like a halo around that. Okay. But yeah, look up different Warthin Finkeldy pictures. So I mean, if someone gets the flu and then they present 2 weeks later with lobar pneumonia, I'm thinking of Staph aureus, guys. Okay, that's secondary bacterial pneumonia, secondary to the virus. Okay, I mean, this isn't really unique to influenza necessarily. Okay, this is just a lymphocytic infiltrate. Why is that important? Lymphocytes, right? Lymphocytes are the ones responsible for viral infections. It's not a neutrophilic infiltrate. Okay, little small purple dots. When you see that, you're thinking of lymphocytes. Okay. Could be helpful. I mean, you're gonna have to associate this for the other questions on the exam anyway. Commit it to memory. Acid fast is mycobacteria. Okay. If she has pneumocystis on any of the slides, then I will go over it, but I haven't seen it yet. But that's pretty much all I would. I mean, that's as much as I would go into that. Now, let me see. Okay, this is unique. You can't miss it. You're not going to get this. Okay, you're going to get this. Okay, literally, like, look, guys, this is a very unique picture. Okay, this, if she puts this on your exam, it's a gimme. It's literally a gimme. It's aspergillus. Okay, don't, or aspergillus, whatever you want to, however you pronounce it. Okay, but don't miss this question. Okay, very, very, very gimme. Okay. All right. Very, very, very high yield. The most high yield thing in the entire PowerPoint is right here. For your future, for the exam, for the COMLEX, for whatever you're going to get into, you're going to be tested on this. Okay. You have to know this. Okay. You have to know. This right here is the most high yield one. Between 250, so 200 and the number 50, not 250, 200 and the number 50, you're thinking pneumocystis. Okay. Below 50 is the severe CMV and the MAC complex, okay, MAC and CMV. But pneumocystis, you're going to, if you get a CD count and it's 140 and they have bilateral interstitial infiltrate, it's pneumocystis pneumonia until proven otherwise. No other answer, period. Okay, you need to know this. You have to know this. Okay, CMV, MAC are below 50. Okay, between that and 200 is pneumocystis. Okay, you're going to hear CD4 count for the rest of your life. Okay, there's the picture. All right, if you get a silver stain on the exam, it's most likely pneumocystis jirovecii. Okay, but the way I remembered this was you literally see like this almost, it's not perfect, but it's like this blob of purple that just sits there. Okay, why is the name jirovecii not used anymore? I mean, for a while, I think they just called it pneumocystis pneumoniae, or AE at the end. But honestly, either one, I think she's probably gonna test you with jirovecii. Okay, and I'm just saying that because it sounds pretty cool and it sounds Italian, so I'm just gonna say the jirovecii thing. But know that it's also called, I think, pneumocystis pneumoniae with the AE at the end, I believe. But the hallmark of this, if you're going to get tested on it, like I said, is CD4 count between these two. And if she tests you on it again, she doesn't give you a CD4 count, you're going to see this. And do you guys notice that you don't really see anything inside of this purple blob, this pink blob? You don't see much inside. You just see this, like, these small little dots in a purple organized, relatively organized blob. Okay. The reason why we even do the silver stain is that you can't see the actual spores or cysts until you actually use the silver stain. That same picture, I mean, I guess this isn't like the most perfect equivalent, but you'll literally see the spores in there after you do the silver stain. Okay, so that's the point. This is just a meshwork of like surfactant and lipids, and it's just a pink blob, and you'll always see that like that white outer side of it. Okay, it doesn't take up the entire area. It's almost always surrounded by that like white coating on the outside. Okay, that's the normal alveoli. That's just the way I remembered it. Okay. Does everyone understand the importance of this slide and this slide? Just rinse and repeat the okay and the yes. You have to know this. You have to know it. Okay. All right. CMV is relatively very unique when you look at it. You just see the inclusions on the inside. I know now you're probably like, dude, you showed us HSV and you saw those like perinuclear halos or whatever the heck I said. And then we talked a little bit about the Cowdery or the Warthin-Finkeldy cells in measles. You just need to like find your way of knowing the differences and using the rest of the vignette. Okay. If you get a CD count, a CD4 count, and it's below 50 and you get a picture with inclusions, you're not going to pick herpes. Okay. Period. These people are immunocompromised. You pick CMV. Okay. It's just an overall picture of how it works. All right. More, just more of that intranuclear inclusions, intracytoplasmic inclusions. Okay. All that stuff. For the most part, that's the way I would approach this lecture. Okay. You have to know CD4 count. You have to know difference between interstitial pneumonia and regular pneumonia, and then be able to use, what was the other one? Hepatization. In my opinion, those are the three questions coming from your exam. Hepatization, interstitial versus regular pneumonia, and CD4 count. Okay? Let's keep going. Pathology, respiratory. Anyone have any questions? Feel free to ask while I pull up the slide. Why won't the chat pull up anymore? 1 second. Sorry, guys. All right. From current slide, laser pointer. All right. So a lot of this exam, the questions that are going to come from this PowerPoint, excuse me, is going to be a lot more buzzwordy. Okay. It's going to be a lot more buzzwords. It's going to be knowing the region. Literally, I'm kid you not. Even on your COMLEX and USMLE exams and the one you're going to be taking in a week, it's literally going to be based on location. Okay. You're going to have to know the Ohio, Mississippi River Valley idea for the histoplasmosis. And you're going to have to also know that it has to do with sport. Like you may get a person who comes in from an Ohio or Mississippi River Valley, right? Like, you can look at that region. It'll be really obvious, okay? And you're going to need to know that, oh, this happened due to spores from bat or bird droppings, okay? The classic thing for histo, I think on Sketchy was like the cave, okay? Bat droppings and bird droppings from the cave, someone who recently went into a cave. You're going to have to just memorize that stuff, okay? Let me see here. Sorry, just moving something on my screen. All right. And it is somewhat important to also know the way that they resist, being degraded. Okay. What do I mean by that is, first of all, this thing is inside of a macrophage. Okay. Good luck killing that macrophage, right? That in of itself is a very, very strong way of avoiding degradation. Okay. And these cause the caseous necrosis, granulomas with caseous necrosis. I'm trying to create a story for you guys as you look at these things. Like I said, that's kind of the challenge when it comes to even like tutoring this stuff. A lot of it is memorization. And so I really just want to point out the most important things from histo, the most important things from each slide, because concepts are minimal. It really is, unfortunately, for this exam. Okay. So you really just have to put in the time. You have to know where the infection happens. And okay, I mean, type 4, unless I keep looking in the PowerPoint and I see examples of something that's like not type 4, don't really stress that too much. But you need to know that it's intracellular and they're spores, okay? In Ohio and Mississippi River Valley, okay? Caseating central necrosis. Cool. I mean, fibrosis and calcification, like you're going to see that in a lot of different things. Most of these people are going to be immunocompromised, okay? Whenever you get an infection from histo, crypto, all that stuff, most of the time these people are immunocompromised, but I wouldn't worry too much about that because, you know, she could throw, that's not going to be the hint on your exam. She's just trying to point out that they don't have granulomas because they don't have an actual immune system to create it. Okay. But anyway, very constitutional symptoms, guys. Like the symptoms, the fever, cough, and night sweat. That's not going to help you get this question right. Like I said, know the location. Please know the location. It's a gimme question if you know that. Okay. You know the location and you know the general idea, then that'll take care of that for you. Okay. Let's keep looking here. Let's see. I think it's really not going to be the picture that gives away histo for you guys, because it's, I mean, I guess it's, to me, it's not really unique. Okay. To me, it's not really that unique. You need to know the idea behind the vignette for that. Okay. Now the pictures are going to help you out in other things. Okay. The pictures are going to help you out specifically when we look at broad-based and narrow-based budding. Okay. That's buzzword. That's super buzzwordy. Okay. So blasto is, I would worry more about the visual, the actual picture of blasto. Okay. So, okay, has a thick cell wall that, this is important. If she's going to ask you anything about blasto's actual mechanism, this is the high yield one. Resisting phagocytosis due to its cell wall. Okay. That's important. That is important. Okay. Bad one. I mean, that's not really, I would just always go back to this idea. Thick cell wall, resisting phagocytosis. Double contoured cell wall. You look at the picture, like literally just look at it. Okay. Let's see where the broad-based budding. I just remember that because of B. Blasto, broad-based budding. Okay. And she's contrasting that with crypto's narrow-based budding. Okay. So just be sure, this is probably a question on your exam. It probably is a question on your exam. Okay. And what I would do if I were you is I would emphasize going on Google and I would look up blastomyces or blastomycosis, broad-based budding, and then look at crypto, narrow-based budding. Okay. The way I see it, like this is right here, you can tell. I mean, this picture is completely different. It's a different stain, but that's the way I would approach this. Go on Google and look at multiple examples. It really doesn't even take more than a minute to get this down. Okay. Not really that important. They're all pretty nasty and they can cause a wide variety of problems. That's not what she's testing you on. Coccidiomycosis, southwestern USA. That's important. West and southwest. Okay. Compare and contrast. Histo is Ohio and Mississippi River Valley area. Okay. Caves, bird and bat droppings. Coccidiomycosis, western and southwestern USA, New Mexico, California, you know, that whole area. All right. I mean, rodent burrows, I mean, cool. You can add that, but it's not really that. So let me see. She usually does put things in red. Okay, so San Joaquin Valley Fever Complex. That is high yield for like in the future, but you know, it's just associating it with coccidiomycosis, okay? Constitutional symptoms and erythema nodosum. You're probably not going to be tested on that on your exam. She has a picture of it, but it's pretty unique in a way, okay? You just see these like faint red dots or bruise like, really faint bruise like pictures on their legs. More often than not, it's literally bruisey colored, like pinkish on their legs. Okay, and just associating San Joaquin Valley complex with coccidia. Okay, southwestern USA. You have to know that. You won't get the question right without knowing that. Okay. Okay. Thick-walled, non-budding spherules. This is the important word here. Spherules. Okay. They have a bunch of endospores in them. Look at it. This is a pretty bad resolution picture, but if you look at it, you see how there's a bunch of dots inside? It's not like the other pictures where we've seen like a nucleus, a confined nucleus, okay? You can literally see these dots inside of these circles, okay? Guys, let me tell you how I survived respiratory for the most part, especially this block. I can't emphasize it more. I made Anki, whatever you want to pronounce it. I made flashcards, Quizlet, whatever it is. You need to prove to yourself you know these pictures. Okay, if you're one of those people that look at PowerPoints and you know it because you look at it for so long, I congratulate you. I was never able to achieve that. I could not ever do that. My way of proving to myself that I knew the information was always actually having pictures of the actual stuff and just hammering it into my brain, because you've seen how so much of this is actually memorization. Okay, it can feel overwhelming, but it's not. I promise you it's not. Just keep the information organized. Spherules. Southwestern USA. Okay. This is really important. Spherules with endospores on the inside. Okay. Look, more of that. I think this is the one she picked for our exam. She really wanted to see if you knew, but you really need to like don't rely too much on like, you need to find the balance between relying on the vignette and relying on the picture. Okay, if you see the picture and you don't know the answer, don't freaking like, don't make your life complicated. Look for clues in the vignette. Okay, if she gives you the location, the answer's done. Okay, you just need to be able to know the secondary information, which is if it resists phagocytosis because it has a thick cell wall. Okay, versus being in the southwestern United States. Okay, and getting these spherules. Okay, did she give us a rupture of the sphere releasing the endospore causes a pyogenic reaction? Okay, that's the other part that I would probably remember if you're talking about pathogenesis. Okay, cool. Like Langerhans giant. That's not the. This is not the high. This is not the high yield part of coccidia. Okay. TB. Oh, you're getting a question on TB for sure. Okay, like almost 100%. All right. I mean, I really don't know how much she emphasized this PowerPoint for you guys in your lecture. This slide, I mean, but I don't remember her specifically being too crazy about the slide for us. It was more so for us getting the general idea, which we're gonna kind of go over in a second as we keep progressing in the PowerPoint slide, right? So primary TB, you're gonna have to know focus versus complex. Obviously, you're gonna have to know lymph node involvement. If you add that to the focus, that's literally a complex, okay? You need to add that into the picture, okay? Complex is just this nasty, like cheesy, gross looking inflammation type picture on the lung. And then if you see lymph node involvement, then most likely you're adding the complex in there. I don't know if she's actually going to make you notice the lymph node being enlarged. That's kind of an advanced skill, I guess. But for the most part, like, I mean, you're 100% getting a TB question. 100%. There's no way you're not. Okay. Let me see. You're gonna have to know the granuloma picture. Okay. You have to know the sorry, I always get confused with the non-caseating, caseating granuloma crap. But we're going to go over kind of the pathogenesis of tuberculosis when we get to Dr. Zirin's slide. We have to keep going, obviously, and go at a reasonable speed when we go over this information. But she really wasn't too tricky with the pictures, okay? Tuberculosis is pretty obvious when you look at it, okay? It's really nasty and cheesy, okay? I hate to kind of ruin that for you, cheese for you guys, but that's just the way it is, I guess. So from now on, for the rest of your life, you have to know that fever, fever, night sweats, chills, and honestly, those three things, you almost always get your tuberculosis alarm going off when you see those three constitutional symptoms. Okay, then you look at more of the history and you see, okay, maybe they were in prison, or they went to an endemic area, or they work in the healthcare environment where a patient recently had TB. Okay, those are the three things that set off your TB alarm when you're thinking about this stuff. Okay. But the idea of tuberculosis is that you get a primary infection where most of the time people actually don't even know they got it. Okay. It's actually really quiet when you get a primary TB infection. Okay. They don't find out until they do a TB skin test and it's positive. They do a chest x-ray, and they might find an abnormality. They might not. Either way, this person is going to be treated because they had a positive TB test. Okay. But anyway, we'll get to the management later on. I just want you guys to be aware of the picture, and kind of the idea of how it goes. Primary infection, they get the primary complex, and then it either goes quiet and gets reactivated later on, giving you the fever, night sweats, and the chills. Or, I mean, like, this is the less likely one. You'll see a picture. You can't miss miliary TB. Okay, but anyways. You'll see that the secondary activation, okay, has a predilection. It really loves the upper lobe of the lung, okay, when it reactivates. It just loves it. You'll literally see this hole in the lung, okay? And that's almost always TB. All right. So caseating granulomas, it's pretty much one of the only things. So, like, look, you have to be sure that you, like, tell the difference between these things. Okay. I'm trying to remember how Dr. Campbell actually emphasized this stuff. For the most part, I think for the exam, don't worry too much about the whole like non-caseating versus caseating. I would stick to the granulomas with caseating with caseating in the middle. Okay, how do I remember that? Because caseating things like looks like cheese, and grossly it looks like cheese. So caseating granulomas is TB for the rest of your life, at least for the exams. Okay. Okay, you need to know a general picture of a caseating granuloma. Okay, you literally have like this circle with a focus on the inside, and it just looks like this meshwork on the inside. Okay. Okay, acid. If you get this question, you get a slide with a purple rods, then please don't miss it. Okay, this is like, we've been talking about a lot of this stuff, and it's kind of challenging sometimes. Don't miss the easy stuff, guys. If you don't make it harder on yourself. Okay, it's purple. It's acid fast. Okay, like don't miss the question about mycobacteria in that case. Okay, we're just talking about how TB can involve different areas. Miliary TB, you're going to see the picture. It's all over the lung pretty much. Okay. And guys, if you feel like when I talk about something, you don't feel like I tackled it enough, email me, please. Please email me. I'm not trying, but since we have a large group, I'm trying to guide you guys for the most part. But if you're struggling, I'm a tutor, right? I'm trying to help you guys. So email me. I don't mind helping you. Okay. Email me and I'll answer your question individually. But don't just go into the exam YOLO, like, okay, he didn't answer the question, screw it, right? Like, email me. I'll help you out. But I'm trying to keep it very reasonable for the amount of people that we have in here. POTS disease, you get a question. If you get, I don't remember her doing this on our exam, but if you get a question with the freaking spine, if you get a picture of the spine period, don't even read the rest of the question. Just pick POTS disease. It's TB that went into the spinal area. And I actually found out not too long ago that my long past actually grandmother, she actually had POTS disease. I couldn't believe it. I come from my family's from Syria. And so, obviously TB isn't treated very well out there. And it's pretty prevalent. So that has I later realized it was very, very relevant to me there. So anyway, scrofula, I mean, the MAC complex. I mean, the fact that she's putting added there means it's kind of like a new slide that she put from last year. So maybe she does want you to know it. It's pretty unique. Like I said, if you put this picture on a card and you literally hammer it in your head, you won't miss it. Okay. MAC complex. The CD count, guys. I know it says 60. Just think of the 50 for now. Okay. Don't complicate it on yourself. Lung and it turns out that MAC can actually cause diarrhea and the picture of a person with TB, right? So I don't really think you're going to get a question about that specifically, but she's just going to want you to know this picture if it's a question about MAC period, okay? The CD count being below 50, which means they're severely immunocompromised, plus this just aggregate of pink rods all over the place, okay? Don't miss it. Don't miss it. That's the end of that one. Oh, I'm sorry. I just saw your question, Armin, the whole lymph node in the photo. I'll send out an email to everyone about that because I actually I'm not even gonna claim to be a baller at like looking for lymph nodes in the histology. I'm just gonna look at different examples and I'm just gonna compare it to what she had in there and I'll send it to you. Okay. So I got you with that, not just leaving you hanging. But I just saw your group chat message there. All right. So does anyone have any questions about Dr. Campbell from what we've gone over so far? Okay. Please ask. Please ask. I don't mind. I'm going to be pulling up what we're going to be doing next is actually, let me see, and review the schedule so we know what the best next thing is. We just finished Dr. Campbell information. Let's go ahead. I'm going to leave micro for last, actually. Let's go ahead and start tackling Dr. Yance and Dr. Weaver's lectures, okay? I'm actually going to go ahead and go over Dr. Yance first because I actually feel like he does an excellent job with explaining the pharm of pneumonia compared to Dr. Weaver. I mean, I love Dr. Weaver, but I remember being in your position and being kind of confused because it was kind of overwhelming having these 2 PowerPoint slides that have all these like different, important stickers on them. If you want to understand pneumonia, I would honestly refer to Dr. Yance for the most part for that stuff. So let me pull up that lecture. 1 second. Let's do upper respiratory tract first. All right. Can everyone see this? Go ahead and just put in the chat. Awesome. All right. So you're going to have to get used to, like, this is not a skill that you'll probably just acquire while we're in here. You're going to have to get a feeling for what symptoms should be triggering which disease, okay? Like sinusitis versus rhinorrhea versus pneumonia or whatnot, okay? We'll see that, and you're going to have to drill that into your head, sort of. But I'll show you what you need to, I mean, like, honestly, he did not test this on this stuff, okay? Okay. That's not what I'm remembering being important. I remember these being the WTF slides. Like I saw the pictures and I was like, what the crap is this? All right. I sort of have a weird memory of the fact that he tested sort of the OPP of this stuff. Okay. I remember him asking what is the best thing you can do for the patient, or what's the best next step, or like which of the following would improve their symptoms or something like that. And it had to do with fixing their facilitation in their spine, in their like, a T1 to T6 problem. And so if you look, like, increased parasympathetic innervation results in thin and watery secretions. So obviously if somebody had really, really thick, purulent secretions, then they were going to have difficulty breathing, or, you know, really thick mucus. And so it was good to actually increase their parasympathetics. I think there's a slide later on that we can, that pops up and is more specific. But I would go back and listen to what he says, like literally personally on the actual media site about it. I remember him putting a question about somatic dysfunction in terms of helping somebody. Okay. Focus on normalizing the structures of the head with cranial. I'm trying to remember what it was, guys, but you know, go back over that. That there was a question during my year about that. Okay. Now, sinusitis. In the real world, it can present in a lot of different ways. Who cares about the real world for now? Okay. For your situation, you need to be focused on drainage, okay, and pain. Whenever, like fullness, whenever you, like, you can literally press their sinus area, their cheekbones, okay? They'll literally feel really full and tender, okay? Have fever, drainage, they're congested. That's a typical sinusitis, okay, picture, right? Facial pain, pressure, nasal obstruction, cool. Don't obsess over these symptoms, but they make sense. Okay. Major versus minor criteria, you know, don't like walk around in your room being like, okay, minor criteria, headache, fever, halitosis, fatigue, dental pain, cough, ear pain. No one cares. Okay. Don't worry about that. Create a story of sinusitis in your head. It'll be obvious. Guarantee it. Okay. So you're just talking about obstruction of the sinus is going to, remember, obstruction leads to infection. Obstruction of the sinus drainage resulted in hypoxia, and they got infected and inflamed. Okay. I sort of actually remember the slide a little bit from whenever I was doing this, when I was in your position. What I remembered was the 4 to 12 numbers. Okay. If the infection has been less than 4 weeks, it's acute. If it's between 4 and 12, it's subacute. After 12, it's chronic. So if you're going to get any question about classifying it, it's remembering those numbers, 4 to 12. Below 4, acute. Between that, subacute. After 12, chronic. Okay. Sinusitis treatments. I mean, dude, you're going to be picking amoxicillin a bunch when it comes to these kinds of infections. Okay. If amoxicillin, if you have in the vignette saying that the person was previously treated for sinusitis with amoxicillin and it didn't get better, you're just going to add clavulanate to it. Okay. That's why they call it augmentin. You're augmenting your treatment, essentially. It was amoxicillin by itself. You put clavulanate on top, it becomes augmentin. Okay. That's like the highest yield. That's the highest yield one for this slide, period. Okay. Okay, inflammation, nasal mucosa, cool. I mean, you know, I think the idea of it being pale and boggy versus red and swollen, okay? Paint that picture in your head. Red and swollen nasal turbinates or mucosa, you're thinking of inflammation. If they're pale and boggy, you're thinking of an allergic process causing congestion, okay? This is really, there's no rocket science here. I mean, look, he says they may have facial pressure and pain, and it just gets so annoying. Like, these all look the same, dude. How am I going to get this right on the exam? I would focus on the keywords that you memorize for sinusitis, the facial pain, the drainage, okay, the congestion, fever, that type thing, okay? Rhinitis, for the most part, usually doesn't actually cause a fever. It's just annoying symptoms, okay? That's the way I would look at that, okay? Eyes tearing up. I don't think of sinusitis when they have eyes tearing up, okay? I think of this person has rhinitis. Inflammation, it could be allergic, could be bacterial. Who cares? It's rhinitis, okay? So now let's look a little bit more at what he's going to be talking about here. The key words here, if you want to paint a picture of pharyngitis, is going to be actually tonsil enlargement and cervical adenopathy. Okay, who cares about the but usually minimal? That's him trying to satisfy the clinical world where you don't have to necessarily have a cervical adenopathy. Okay, but when you see a red throat, red tonsils, you're not going to be thinking of sinusitis, guys. Okay, it's important to keep this very simple for yourselves. Okay, paint a picture in your head and don't complicate it any more than that. Okay. All right. More pictures, exudates on top of the tonsils, the different causes. Please don't freak out about it. Just know that strep pyogenes, which is group A strep, is the one that causes rheumatic heart fever. Okay. And that's why we obsess over pharyngitis, so that people don't just look again. Anterior cervical lymphadenopathy. I think the other one was viral. This is bacterial. This is the stuff that supports a bacterial pharyngitis. Okay. You see the inflammation, they have fever, okay, and they have the anterior cervical lymphadenopathy, okay. For some reason, when I see anterior cervical lymphadenopathy, I'm thinking of pharyngitis, okay. That's the closest thing to a one word for pharyngitis, okay. Absence of cough is actually important in the real world. It could help you. I think it's secondary. Like, just remember anterior cervical lymphadenopathy, and they're not talking about a cough. You're thinking of inflammation of their tonsils, okay. It's important, actually, when it comes to like boards and whatnot. I don't remember how important it was for him, but I think it might be. Just know the anterior cervical lymph nodes, inflammation of the tonsils, and fever with no cough. Okay, just paint a picture of that in your head the best that you can. Okay, most of the time you're just going to be giving these people penicillin. Okay, most of the time it's just penicillin, and most of the time when a person has a penicillin allergy for something that you need to give them penicillin for, the first thing you think of is like either Zithro or Clinda. That's actually that's an ongoing theme that you're going to notice on this block. Okay. All right. So let's not just keep on going. These are the different complications of Group A strep, obviously. Okay. You're going to need to know an idea of them. You could get any question on them. Okay. It would be really, really nice of him if he actually threw a picture of, where is it? Of the tongue one, right? Beefy red tongue with all those dots, strawberry tongue. Jones criteria is just important to be aware of. I don't believe he actually really. The thing is that they're not necessarily going to be testing you on, oh my God, he only had one major criteria, dude. Like one major criteria and didn't have the required criteria. So diagnose it, and then you see rheumatic heart fever or rheumatic disease and you pick it. Like, they're not trying to trick you like that. They want you to be aware that the diagnosis of rheumatic heart disease, right, or not rheumatic heart disease, but rheumatic fever is going to be a combination of serology, right? I like to think of this stuff as the obvious stuff, okay? Okay, this person had a strep infection before, or you test them, they have the antibodies, or they have a throat culture, or they had scarlet fever before, or these tests that tell you, oh my God, they actually are infected, okay? If they're negative, then who cares? They don't have it, right? The stuff that's actually tricky is just kind of finding a way to remember Jones, okay? They have a bunch of pictures online where they make like, they make J the joints. I think they make the O a heart. I think they make it a heart. So, you remember that it's joints, heart, nodes, erythema.
I don't want to interrupt you, but he said not to worry about it, just so you know.
Oh, really? Okay, perfect. Thank you for mentioning that. I appreciate it. So if you're going to get a question on it, don't worry about Jones, obviously, but you may get a question about like rheumatic fever and scarlet fever, and just knowing that it's a cause. Its cause is untreated pharyngitis, okay? Which is why it's important to know to treat it, okay? Doesn't get more buzzwordy than the sandpaper rash and the beefy red tongue stuff, okay? Keyword for peritonsillar abscess is actually uvular deviation, okay? Like, look, the uvula is literally pushed to the side, okay? Hot potato voice, trouble swallowing, cool. That just paints the picture. And then if you gives you a picture and you see the uvula pushed to the side, peritonsillar abscess, okay? Literally an abscess around their tonsils. So for mono, I think most of us kind of have an idea of like, a lot of the stuff that they really like to test on this stuff. The atypical lymphocyte is important to remember for that. Basically, it just looks like this big purple glob that is that's literally getting pushed by the red blood cells. Okay, the red blood cells are making room for themselves by pushing on the cell membrane. It's deformed looking. Let's look at what he has on the slide. So, I mean, rapid monospot test. And so I think what he actually tests you on is actually the titers, okay? The way I would approach this question, if you get it, okay, like he explains it pretty well, actually, okay? It's not that really intense, but so IgG for the rest of your life tells you that this has been a chronic infection, or they've had it before and now they have antibodies against it. IgM means they currently have, like, they're literally acutely infected. But so it gets kind of confusing when it comes to EBV when you incorporate eBNA IgG, okay? Because if you look here, if you follow what I just told you, IgM, if it's positive, it's acute. Well, look here. What if all three are positive? Okay. The thing is that if the eBNA IgG thing, okay, that only pops up when EBV has been in the body for a while and is about to go latent, okay? When it's about to go into a quiet phase. They got it, and it's about to go into a quiet phase. So if you have a positive eBNA, there's no way you have a recent infection, period, okay? So if you see positive eBNA, you're immediately going into the past infection immediately, okay? But I think when I was in your position, he emphasized the IgG component of the VCA. Just knowing that, like he does right here, IgM is new infection, IgG, past infection, or immunity, okay? Don't complicate this on yourself. It's very simple, okay? Probably will get a question on it. I looked it up on UpToDate, and they just basically talk about how it goes latent, okay? But anyway, a really key thing here is actually the fact that when you give people with penicillin or amoxicillin, they get a rash. That is a buzzword big time, or buzz phrase or whatever, okay? Give them amoxicillin, these guys develop a rash. They've had inflammation of their throat for a while, okay? And I think his point with hoarseness is really going to just be about the fact that it's normal most of the time, but you really have to be worried about really, really bad things if it doesn't resolve. Longer than 3 weeks, needs an ENT evaluation. Just emphasizing the picture. On a few weeks, workup for something like malignancy. Okay, epiglottitis. Dude, you guys are going to get a question with somebody who wasn't vaccinated for the most part. Usually this is a kid. It's rarely ever an older person. It's usually a kid having difficulty breathing. You hear this, you hear there's stridor. I would emphasize stridor more than the hoarse voice. Muffled sounds with stridor and difficulty breathing and drooling. Severe fever. Like, these people just look massively sick, dude. Compared to sinusitis, compared to rhinitis, compared to all this other stuff we've talked about, these people are really, really sick, okay? So just envision kind of a very extreme situation here, okay? And most of the time, it's a kid who hasn't been vaccinated, okay? Stridor, drooling, fever, like, it's pretty unique. I don't think you should miss this question. It's not tricky. Okay, and I know he says hip epiglottis can still occur in immunized children, but rarely, okay? His point is that it can still happen, but you're not going to be tricked into saying, oh, he's been immunized, but he still has a muffled voice, and okay, in the real world, you're going to think they might have epiglottitis, but that's probably not how you're going to be tested on it, okay? Be realistic with yourself here, all right? Okay. I mean, okay, this is a question on your exam. This is a question on your exam. I was so surprised when I saw it on the exam when I took this, because I remember him just like going on a big spiel about procalcitonin during my year and how it's this new thing that everyone loves and everything. And it just sounded like he was just in love with it and really wasn't an important concept. But during my year, it literally popped up on the exam, okay? And it's literally used to tell the difference between a viral and a bacterial infection, okay? Most of the time, you literally just order this test in the real world, and if it's positive, then you're worried about a bacterial cause of a possible sepsis, or, I mean, okay, preventing death from sepsis, cool, but you're worried about a bacterial cause for sepsis, okay? Well, it'll be normal in a viral infection. Does everybody hear what I just said? This is probably a question on your exam. It was on the exam, okay? I just want to see an okay, because this is important. I don't want anyone to miss this question. Okay? It's important. All right? I mean, I give you permission to come to Memphis and raid my house if it's not on your exam, okay? Just kidding. But for real, like it was on our exam, and he loves it a lot because it's clinically super valuable, okay? And if it's not, then I mean, it is what it is. I'm just trying to guide you, but he loves it. Okay. Any questions about that lecture from anybody? I am pulling up lower respiratory tract right now. Yeah, thank you, by the way, for mentioning that about the rheumatic heart disease or the Jones criteria, because for some reason the chat doesn't pop up when I make it full screen. So like if anyone ever says anything in the chat, I'd appreciate it if somebody just popped up on the mic and told me, okay? That's like the easiest thing. All right. So this is where things kind of get like really, really high yield for your exam, because, and it's probably where a lot of people actually get annoyed, because it's just like knowing the right answer for treating pneumonia and whatnot. So look, guys, it's here again. It's here again. It's probably a question on your exam. We met with Dr. Yantz during my year. People were struggling with respiratory a large number of our class. And he wanted to start helping people, giving them an idea of what's important. And, you know, he was just like, what else can I do, guys? And the tutors met with him. And I'm telling you, he's not trying to screw over anybody. He is very, 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 his academic side is very straightforward, and very reasonable, okay? Don't miss this question. Don't miss it. He might not test you on it, but he's basically trying to make sure that you know that it's probably being tested by Dr. Campbell, okay? Honestly, for the most part, for the rest of your life on a test, if you get a question about somebody with fever and a cough, maybe septic, like, you know, maybe they're having, you know, the symptoms of fever, tachycardia, low blood pressure. Most part, it's fever and difficulty breathing, and you get an x-ray and you see changes, you're thinking of pneumonia, okay? So let's go into more detail again. I really don't remember him testing us on this. I don't actually even remember if he had this on his PowerPoint when in my year, okay? But it's actually really important in the real world. You know, maybe you guys can help each other on the chat and tell each other how if you feel like he emphasized it or not during the lecture. You know, I don't have access to actually watch your lectures. I only have access to the PowerPoints. So, but it's really not that hard to know, because for the most part, like, you should be able to look at this and tell, okay, this guy's majorly sick. Okay, it's just about, should I bring them into the hospital or should I just discharge them on antibiotics in the emergency room? That's the whole point of it. So if somebody's confused and they have low blood pressure and they're over 65, I'm gonna get sued if I let this patient go and I don't admit them into the hospital. Okay. The trickiest one is the urea BUN. Okay, if it's above 19, it's actually above 20, then you're worried about dehydration. Okay. Anyway, the higher the number, the more likely they are to die if you don't admit them, essentially. Okay. Let's keep going. I mean, he's talking about urine antigen tests. Not okay. I mean, he says know these cold. I remember really trying to learn them. I would say that you need to make sure that you know which one is the most common in what area, obviously. So in the outpatient world, it's almost, I mean, look, strep pneumo across the board, right? Strep pneumo, strep pneumo, strep pneumo. Don't miss it. Okay. But if you get a question about somebody who had the flu 2 weeks ago, you're going to be thinking about Staph aureus. And the flu is pretty common. Therefore, you see Staph aureus on the lists a lot. Okay. Under ICU, walking pneumonia, the mycoplasma is secondary. I don't think you should go as far as, oh, wait, I think I remembered this. I think I just remembered what popped up on our exam. He might have actually tried to be tricky here. I think his question was, which of the following agents is a most likely cause of pneumonia in the outpatient and the non-ICU setting? I think it was a tricky one, actually, maybe. And I think he was trying to see if we remembered where that chlamydophila pneumonia was on both of these lists. That outpatient, and that's the trickiest question you'll get from this list. Okay. I'm sort of feeling like maybe he trolled me on this. I don't remember if he trolled me on the exam, but that's as tricky as it'll get. Okay. If he doesn't ask it like that, it's not going to get any harder than that. Know the first two. Okay. And know that chlamydophila pneumonia is on both the non-ICU and the outpatient list. Okay. So anybody who's not in the ICU that's in the hospital can get, it's just a third and fourth most common cause here. Anyway, that's the best I can do, I think, when it comes to this list. All right. I'm going to explain this just because I feel like when I was in your position, I felt overwhelmed with all the other information. And so I was just like, okay, I don't care about all these different kinds of pneumonias. Just tell me what I need to know. Okay. Look, community acquired, you have no exposure to anything in the healthcare world. Okay. You haven't had dialysis. You haven't gone to a nursing home. You haven't done any of this stuff. That's just community acquired pneumonia. Okay. And I can end up with strep pneumo or mycoplasma for the most part. Okay. Now, healthcare associated is people aren't necessarily, okay. The thing is that technically hospital acquired pneumonia and ventilator associated pneumonia fall under the healthcare associated pneumonia list, technically, right? But not all healthcare associated pneumonia is necessarily due to the hospital or a ventilator, right? So people who go to nursing homes, people who go to dialysis centers because they have end-stage renal disease, okay? These people can get healthcare-associated pneumonia. And whenever I think of the healthcare world with pneumonia, I start to worry about two things, MRSA and Pseudomonas. Those are the two things that I get worried about when I think of healthcare pneumonia, period. Whether in the hospital, ventilator, whatever, okay? They had any sort of exposure to the healthcare world, I'm starting to be worried about MRSA and Pseudomonas, okay? And you're going to have to commit to memory the two drugs, for instance, that are very, very MRSA, the ones that target MRSA, the ones we like to know are vancomycin and linezolid, okay? Vancomycin and linezolid. Those are the two vancomycin most common drugs for MRSA, okay? We'll talk about Pseudomonas in a bit. Anyway, so if you have recently been hospitalized, okay, you got hospitalized and you've been in the hospital for at least 48 hours, and day 3 or day 4 of your hospital sitting, you get pneumonia, then we like to believe, based on research, that you acquired it because you were in the hospital period. We label it as, okay, you got it from the hospital. If you got it on day 2 or day 1 of your hospitalization, that's too early for a pneumonia to develop for the most part due to the hospital setting. Okay? 48 hours after being hospitalized is the definition for hospital-acquired pneumonia. Okay? Now, in the real world, some of these are actually disappearing. Okay? I think hospital-acquired pneumonia is actually no longer in the guidelines. I'm just throwing that out there for you to be aware of that. But for your exam, it's on this slide, so it still exists for your purposes, okay? Aspiration pneumonia. Guys, I'm asking you right now in your head, what is the most likely cause of a pneumonia if they were aspirated? The answer is Klebsiella, okay? Klebsiella. Why? Because most people who have alcohol problems who get altered mental status very frequently, they get impaired. The glottic reflex is impaired, so they're more likely to aspirate. In most aspiration contents, the infection is going to be due to anaerobic bacteria. Okay. Cystic fibrosis, I get worried about Pseudomonas. Okay. I'm giving you the general idea in your brain what you need to be thinking. Cystic fibrosis, I think of Pseudomonas. Aspiration pneumonia, I'm thinking of the alcoholic or the altered mental status patient who has been, on the ventilator or whatever, right? Like they have altered mental status, so they have an increased chance of aspiration, period. Obviously. Now, HIV. HIV, when I think of this, I think of pneumocystis jirovecii. Okay, I start to think about that. I start to think about the disease that is between a CD count of 250. Okay, 250. So 100, 150, 180, 80, fill in the blank. I think of pneumocystis jirovecii. The go-to drug for that is TMP-SMX. Okay, trimethoprim sulfa methoxazole. You'll see it in a bit. I'm throwing that out there because it's important to know. All right, let's keep going. Lobar pneumonia, okay? Literally a lobe. Another lobe, okay? Not tricky. This is not walking pneumonia. If somebody gave me this PowerPoint slide on my exam and said, what is the most likely cause? I'm picking strep pneumo. If they ask me, what is the most likely morphology of the person, of the bacteria that is affecting this patient, I'm going to pick lancet-shaped or diplococci, gram-positive diplococci. That's strep pneumo, okay? Someone recently had an influenza infection and they had some sort of viral infection and then they got better and then they got worse later on. I'm thinking of Staph aureus, clusters, gram-positive clustered cocci, okay? I'm just hammering this into your head. I want you to hear it 5 billion times, okay? So, literally they all end, most of them end in pneumonia, okay? For the atypicals, intrinsically resistant to beta-lactam agents, which is why we're going to end up giving them different drugs, okay? Namely a macrolide, azithromycin most of the time, okay? But let's keep going. This is all listed. What I'm saying, I'm just trying to kind of get it in your head. Risk factors for community-acquired pneumonia, okay? I mean, cool. Alcoholism, asthma. I mean, honestly, don't memorize this, okay? Don't memorize this. Makes sense. What are some things other than the hospital that would cause somebody to get pneumonia in the community? Yeah, he has alcohol, asthma because of impaired clearance, hyperactive mucosa, whatever, okay? Treatment of adult community-acquired pneumonia. So if you're probably going to get a question on your exam that's going to give you a person who comes to you in the clinic or comes to the hospital and they don't really look too sick, but they've just had this cough that won't go away. They don't have difficulty breathing, okay? They just have this cough that won't go away. Maybe they had like 100 and 100.2, maybe like 100 whatever fever. It's not too severe. They don't look too sick, but they clearly have, you look at their chest x-ray and they have, let's say, bilateral infiltrates, okay? Or whatever, okay? Like I said, these people don't look too sick. You're probably going to just give them azithromycin and say, come back if you get worse, okay? Most of the time, it'll take care of it and they're fine, okay? That's what I would remember from this scenario. Azithromycin, a macrolide, azithro, erythro, clarithromycin. Those are the different ones, okay? Now.
There was a question.
Yeah, sure. Oh, there's a question on the chat. Let me see if I can pull it up. 1 second. Let's see. Even though that x-ray was more patchy than consolidated, number one is strep pneumo. If it was more, no. So the x-ray, if this person was, if the x-ray shows bilateral interstitial infiltrates, right? Like you literally see this hazy picture on both sides of the lungs, then I'm not going for strep pneumo. I'm going for mycoplasma pneumonia, okay? But that's no problem either way. Azithromycin should take care of the problem, okay? That's the purpose. That's the reason why that drug is so good for that case. Okay. But if you had like a lobar consolidation, strep pneumo all the way. Okay. But most of the time, they're not going to test you based on just like, here's an x-ray. If they give you an x-ray and you see bilateral interstitial infiltrates, you're going to have a vignette with it, period. This patient comes to you, doesn't seem too sick, bilateral interstitial infiltrates, I'm picking mycoplasma. Okay, walking pneumonia. Does that answer your question, by the way? Awesome. Let's keep going from the current slide. All right. So, uncomplicated inpatient treatments. We'll get back to that. We'll get back to this stuff. This is not the priority at the moment. We get a slide that will help us understand what we're doing even more very soon. All right. Healthcare associated pneumonia. Cool. This is the kind of stuff where people are just they're exposed to some sort of healthcare. Okay. Dialysis, just, you fill in the blank. Okay. We start to worry about MRSA and Pseudomonas in this position. Okay. So let's get to the crux of the treatment. Okay. Has attended hospital hemodialysis clinic within the previous 30 days. Okay. This is just basically saying that there's research that says after somebody has some sort of healthcare up to 30 days, they actually are at risk of getting some sort of infection. And if they do get a pneumonia, it's most likely healthcare associated pneumonia. That's all they're saying. Okay. And it's going to be obvious on your exam. They're going to say this person was hospitalized 3 weeks ago. Okay. And you're going to be worried about healthcare associated pneumonia in this case. Okay. It's going to be obvious. Opportunity Pseudomonas, cool. And the whole emphasis here is that you need double coverage for these. Okay. And they're mentioning he's mentioning fluoroquinolones and aminoglycosides, cool. But he has a really good slide that comes up. Okay. Staph aureus, methicillin, okay, linezolid and vancomycin. Okay, you need to know that. All right. Double gram-negative coverage. Pick one member from 2 of the 4 classes. Okay. I swear, when I first saw this slide, I was pissed. I was just like, dude, this is so much. Like, I hate antibiotics, all right? But don't make this difficult on yourself, okay? Right here, he's basically just telling you what drugs cover Pseudomonas, okay? And it's really nice that he's doing that, okay? You need to know that cefepime and ceftazidime take care of Pseudomonas. Those are the cephalosporins that take care of Pseudomonas, okay? Now, you probably know that the carbapenems, imipenem, meopenem, whatever, those are like the big gun antibiotics. So it makes sense that they do cover Pseudomonas, okay? Now, the beta-lactam, beta-lactamase inhibitor, Zosyn, okay? This is going to be the most common drug you're going to hear. This is going to be one of the most common drugs you're going to hear for the rest of your life, okay? Piperacillin, tazobactam, okay? These are the 3 options that you have from this list to pick for Pseudomonas. When we go down the list to the second choice, you can only pick between a fluoroquinolone and an aminoglycoside. Okay, look back over here. Look here. He mentioned fluoroquinolones and aminoglycosides here. Okay, so we now know that those 2 are very, very important in that they cover Pseudomonas. So you can only, when you're looking for drugs to cover Pseudomonas, you're going to be picking from, most likely, you're going to be picking either between Zosyn, piperacillin, tazobactam. I'm going to say Zosyn from now on because it's quicker. You're going to be picking between Zosyn and cefepime or ceftazidime. Those are the most common ones. Okay, if you see imipenem and meopenem, you're going to just remember that carbapenems are big guns. Okay, so they clearly cover Pseudomonas. Okay, but the ones I want you to commit to memory right now are Zosyn and ceftazidime or cefepime. The cephalosporins that cover Pseudomonas are those 2 and Zosyn. And then I'm going to add either a fluoroquinolone or an aminoglycoside. Okay, you're gonna have to write this down over and over again just so that you kind of cement it in your head. But I promise you, it's not that hard after you go over it. Okay, you separate these into two categories. I'm either gonna pick from one of this list and one of that list: Cipro or Levo, or amikacin, gentamicin, or tobramycin. Okay, now if somebody recently had some sort of exposure to healthcare, obviously you're going to be worried also about MRSA, okay? Linezolid and vancomycin. All right. So basically, this slide does a really good job at classifying the drugs based on what we're worried about. Okay. Worried about Pseudomonas, refer to this list. Worried about MRSA, these are the two that you're going to be worried about the most. You're going to be picking the most likely. Okay. So honestly, I wouldn't really worry too much about this particular slide. If it helps you, good for you. If it doesn't, don't worry about it. There's a better slide coming up. And he's just hammering more about the things that make us worry a lot about the resistant drugs, the resistant pathogens like MRSA or Pseudomonas or whatnot. Okay, and like these make sense. Over 65, we generally think of being relatively immunocompromised. Male gender, that blows, but it is what it is, I guess. Previous antibiotic, it's obvious. Okay, previous antibiotic therapy, a bunch of different bad diseases. Don't freak out about that. Okay, like you're most likely not going to get a question that's just like I don't know how you could be tested on this period. Okay, just read it, make sense of it, and have a way to, when you look at it, summarize it in your head. All right, so 48 hours after an admission is hospital-acquired pneumonia. We're worried about what? Pseudomonas and MRSA at this point. It'll imitate HCAP. Basically, you treat healthcare-associated pneumonia and hospital-acquired pneumonia almost the exact same way, based on what you're worried about. So what's the game here? For the most part, what's the game? The game is that you need to know when you're worried about MRSA and when you're worried about Pseudomonas, right? So when you learn those, which I mean, as we keep going, you'll fill those spots in. When you know what those risk factors are, when you get them in a vignette, you're gonna know, oh, I'm worried about Pseudomonas. So I need to pick one of those three things that were listed in the beginning, the either ceftazidime or cefepime from the cephalosporins, or a carbapenem, or Zosyn, right? And then I'm either going to pick an aminoglycoside or a fluoroquinolone to be added to it. I need double coverage, and those are my choices, okay? And then if I hear somebody having a catheter put in, right? They have a central venous catheter put in, I'm worried about MRSA, okay? So I might put these people on either linezolid or vancomycin, most likely vancomycin, okay? But anyways, let's keep going. Ventilator-associated pneumonia, empiric coverage includes a carbapenem or Zosyn, right? Like, see, look, this is not really that special, guys. It's on that list. You pick Zosyn, a carbapenem, or one of those two cephalosporins in the beginning. Maybe this is just what medicine is like, but what if you had to pick one? He's not going to make you pick between a carbapenem and Zosyn. He's not going to put a fluoroquinolone or aminoglycoside plus a cephalosporin. Like, that's just not really, he's not trying to do that to you. From now on, remember, ventilator, that should send off the Pseudomonas alarm in your head. And you're going to be picking this. You're going to be picking one of these and one of these. It's that simple. Don't make it harder on yourself. Does everyone understand what I just said? I want to see it in the chat. Yes or okay or whatnot. Ask a question right now about this. I want to see a question about this if you have one, because this is where most people get tripped up. I guarantee it. There is no dumb question at this spot. So please ask it if you have one. All right, let's just keep going then. If you do get a question later on, ask me. I don't mind. Just email me or private message me and we can explain it after. All right. But please don't go into your exam not knowing this. All right. All right, let's see. Um, oh man, I just got so upset. I just looked at my fantasy football and I'm losing so badly. This sucks, dude. Okay, anyway. All right. Ventilator associated pneumonia. We know that that's Pseudomonas that we're worried about. All right. Aspiration pneumonia. Would it not be safer to put them on MRSA and pseudo coverage if you're not sure and they have been in the hospital with catheters? Yes. So that's the question actually in the real world, where if you're a lot of people who are in the hospital who develop pneumonia, you're going to put them on vancomycin. You are going to put them on anti-pseudomonal coverage. And so that's a very good question. Like you will be, if you're, just because they haven't been on a catheter doesn't mean they don't have MRSA. Okay. So in the real world, like you're worried about that. Okay. And I actually had a good number of questions on my step 1 USMLE that had people with catheters in, and they were saying, what is the most likely antibiotic coverage you need to put in? And they were just testing if you knew that in hospital acquired anything, period, you're worried about MRSA and Pseudomonas, and you had to know what antibiotics you put them on. So that's important. Okay. Thank you for asking. Does that sort of answer your question a little bit, Allison? I know it's not like a perfect answer, but so let's see, aspiration pneumonia. Awesome. So anyway, we talked about that already. Impaired swallowing reflex. You're gonna have problems. You're gonna most likely get an anaerobic bacteria. Okay. So that's why you start seeing things like clindamycin and metronidazole, guys. These two are very good at covering anaerobic bacteria. It makes sense. Okay. Make sense of that. Anaerobic bacteria and aspiration pneumonia, I need a drug that covers those. Namely what? Clindamycin and metronidazole. Sure, Zosyn is a very good drug for that. But if you see metronidazole or clindamycin on your exam, don't freak out, okay? Those need to be hammered into your head as medications that are used when you're worried about anaerobic bacteria, period, okay? Kind of bear that in mind. All right. Cystic fibrosis, I'm worried about what? I'm worried about Pseudomonas. And if I'm worried about, you see how like there's no clear-cut situation here. He's not like, okay, add oxacillin if you're worried about methicillin-sensitive Staph aureus, but add vancomycin if it's methicillin-resistant Staph aureus. He's not giving you a straightforward situation here because they're going to be testing to see if you know, if they give you an obvious example of a person with a certain disease or risk factor, do you know what antibiotic to put them on to cover them? That's what they're testing. They're not trying to see if, oh my God, well, you should have been worried about you should have been worried about MRSA and methicillin-sensitive Staph aureus. And no, don't make it scary on yourself. That makes no sense. Don't do that to yourself. You need to know the ox, NAF, clox, diclox, those are the ones, dicloxacillin, napacillin, oxacillin. Those are the ones for regular Staph aureus. MRSA comes in, vanco, and linezolid. I'm trying to classify these in your head. You need to make a table. Don't just put this in your head. Write it down. You still have a week of information that's going to come in. Don't just get all cocky and be like, I got this down, I'm done. No. Respect it, honestly. Don't let the exam remind you have to respect the stuff. Okay? Okay, so anyway, PCP. Okay? Pneumocystis that's what it's called. Carini or Giardice. Sorry, it wasn't pneumocystis pneumoniae. I was stupid when I said that. Pneumocystis current. I think people still call it Giardice in the real world because not everybody is like really caring too much. This is probably what like our like kids will probably call it. Who knows? But if they're in medicine. But anyway, you need to know TMP SMX, Bactrim, or trimethoprim sulfamethoxazole. 100%. Dude, they don't even put this when a patient's CD count drops below 200. They don't wait till he gets it. They just put him on it. Okay? That should show you how important it is for you to know this. If their CD count is below 200 and they have HIV, you put them on TMP SMX. If an HIV patient has a normal CD count, okay, they come in, you have their history of HIV, you do their CD count, and it's 600. Guess what? They're not at risk of getting pneumocystis jirovecii. Okay? If you get a question, I'm just mentioning this now. I want to get this straight for you. Okay? There's actually a UWorld question that pops up every year. It says, it gives you a patient with a CD count that's normal, okay? And they have pneumonia. They don't give you an x-ray. They just tell you that they most likely have pneumonia, okay? The most likely pathogen for a patient who has HIV and pneumonia but has a normal CD count is strep pneumo. If their if their CD4 count is not below 200, they're not immunocompromised, guys. The CD4 count is what tells me they're immunocompromised. So if it's below 200, I'm putting them on TMP SMX, okay? And the most likely cause, if it's below 200, is what? It's pneumocystis jirovecii. If they have above 200 in CD count, right? They're not going to give you 202, guys. If it's like 400, 500, 380, whatever, you pick strep pneumo as the most likely cause of their pneumonia if you don't get a chest x-ray. Okay, most of the time you actually won't when they're testing epidemiology. Okay, does that make sense? I want to see messages. I want to see the okays and yeses just so I know you understood me there. Okay. Awesome. Okay. So anyway, I mean, and anything else that's like cancer, lymphoma, sarcoma, whatever, these are people that are immunocompromised. Don't complicate this on yourself. It makes sense. Physical exam. Okay, these are just ideas of people. These are literal. Facilitation in T1, T6. Literally treating this can help a person with pneumonia. Just like I said, put a note and refer to the media site lecture to figure out what he emphasized about osteopathic treatment of pneumonia or any form of upper respiratory infection or whatever. I remember being tested on it. Primary goal is to normalize the patient's mechanics. Treat the sequence of areas of greatest restriction. Do your best to normalize the thoracic region, okay? So you're literally looking for anything that can cause a restriction in the thoracic region whenever the person has pneumonia, okay? Rib cage can restrictive, just go back to what he says, okay? And then make the best judgment call when you get the question on the exam. Guarantee you, if you make your best call, everyone else is probably going to pick the same thing. And if it's wrong, then he's dropping it, okay? Literally, that's how you have to start thinking. When you put in all this work and you get a question on the exam that you're like, what the hell is this? What do I choose? This is ridiculous. You need to pick what you think everyone else is going to pick that probably studied the material well. You pick it and you move on. And it's either going to be double keyed, dropped, or the right answer. Okay? Think that way. Okay. Anyway, incentive spirometry. I mean, it's a way after people who get pneumonia, you put them on this. It's the best way to prevent future causes of pneumonia, prevent atelectasis, which is, you don't want to get irreversible dilation of their destruction of their alveoli. If you don't use it, you lose it. So they blow into this thing, and it basically, they start coughing up some sputum, and it gets rid of that stuff, that nasty stuff. It's a good thing. It gets rid of it from their lungs, and it's part of their treatment, period. Okay. Anyway, influenza infection, abrupt on fever, headache, myalgia, cool, just a bunch of respiratory symptoms, complications, myoglobin, rhabdo, I mean, I've never seen anybody who gets influenza and then gets these things, but it's possible. Okay. Guys, if somebody got influenza and they got bacterial pneumonia, write in the chat right now, what is the most likely cause of it? What's the bacterial agent? Cool. Please don't miss that. Please don't miss that. I'm begging here. Okay. Don't miss that. Know this stuff. Very good. Myositis, Rye syndrome, bacterial. Okay. I mean, this is not necessarily super high yield, but it'd be good to kind of refresh on Rye syndrome, how it correlates to it. Higher risk of complications from influenza. Guys, this just keeps on coming back. Pregnant, over 65, and really young. The really young and the old are most likely in nursing homes, right? Not the really young, obviously, but anyway. And chronic diseases like asthma, immunodeficiency, okay, cool. It's not really worth being worried about. Irreversible airway dilation, that's bronchiectasis. Guys, how do I get airway dilation from, I'm going to get this when I get something that it causes obstruction. whether it's a tumor that presses, and so you get dilation distally, right? That area is going to get so infected and it's not going to be aired. Remember, don't use it, you lose it. So if air doesn't get there, if you don't inflate that alveoli, it's going to get irreversibly damaged and it won't do it anymore. Okay. You aspirate a foreign body and it blocks the alveoli. Compression from a lymph node, it gets scarred and it won't move anymore. Okay. Like, it makes sense, but you need to know the definition of bronchiectasis. Look at this big list of crap that causes it. Okay. I mean, I'm trying to think of a way to approach this slide, but honestly, like, don't really worry too much about that kind of stuff. Clubbing, persistent cough. I'm just trying to focus on what we need to worry about here. Like, usually these people are going to have some sort of compromise to their airway flow. They've had pneumonia 8 times in the last year. Okay. And now they're coming to you and they have some hemoptysis, foul smelling sputum is the key word here for bronchiectasis. Okay. And usually you need imaging. It makes sense. You see how these little dots here that you don't see, it's really dot, but then here the dot gets bigger. That's the airway being dilated. Okay. Alpha-1 antitrypsin can cause it. Cool. Treatment, you take care of the offending agent. Okay. If they keep on getting pneumonia, you got to stop them from getting more pneumonia. If they keep on getting exacerbations from their COPD, you need to help them stop their exacerbations of COPD. If it's because of some inflammatory process from like Sjogren's disease or all these weird ones on these lists, you give them steroids and you stop it. You see what I'm saying? It's not like you have to target the problem. Lung abscess, it's back. Okay, cool. Destruction of the lung parenchyma, guys. You lose the architecture. Yes, you do get the foul smelling sputum here, but for the most part, you're not going to you're going to look at the history. You're going to see, is there a reason why this person should have had an abscess? Have they just had this pneumonia that they just haven't gotten treated for a while? What's going on? And then you do an x-ray and you see this big hole in their lung. Okay. It's not one word that's just going to make you pick lung abscess between that and bronchiectasis. They both cause really nasty smelling sputum. Okay. And in the fever, maybe the fever pushes more into lung abscess range, I think. But, I would say pain, fever, and foul smelling sputum, I'm scared of a lung abscess at this point. Patient who's recently had a bunch of pneumonia and now they have cancer and they're having difficulty breathing, I'm thinking of bronchiectasis. Okay. It's a story and you just need to fill in those details. Does anyone have any questions about that lecture? All right, I'm referring to the list. Okay, so now what I'm going to do is I'm going to go ahead. Now we'll actually get through Dr. Weaver's lecture much more quickly, because, again, there's only so much I can do for some of the, you'll see what I mean. Where's Dr. Weaver's Farm of Upper Respiratory Infections? Share. Okay, this is probably the most worrisome lecture for a lot of people because they just don't know what she'll probably ask. Let's see. She's really good about the red stuff, by the way, about if it's not red, then you're not. Oh, wait, this is not the infection. This is you know what? Let's just go ahead and get this one out of the way then. It's not too bad. So this is actually not the respiratory infections. This is just the respiratory, I think it's just respiratory system farm. We already talked about allergic rhinitis. Remember, pale and boggy, not red. You don't see the inflammation as much from the red nasal area. You think of pale and boggy, right? And she wants to just make sure that you remember that H1 is primarily, we're thinking of everywhere else in the body. And H2 is really gastric focused. Are we planning on doing all of respiratory today? What I'm planning on doing is actually, because there's so much memorization and it's not as much explanation, I'm actually going to start moving a lot quicker. and I want to be able to address from each lecture what you guys need to. Oh, 5 p.m. cardio. Okay. What time is okay right now? Oh, okay. So you have tutoring in like 3 minutes, right? Okay, I see. Um, yeah, and it's probably a good number of other people. So in that case, I mean, it's recorded. It's actually recorded. So what I'll most likely do is I can just I'll have a file and I'll be able to send it to you guys. And if you have any questions, you know, I'll if you have any questions from this information at all that I didn't address during the actual recording, then feel free to email me, message me. I can schedule another session to address a lot of people's questions, but you know, you don't have to feel pressed to, you don't need, you go to cardio, do your thing. That's no problem. But I'm going to keep this session rolling. I'm going to address everything. And yeah. So anyone who has to go to cardio, you do you. That's not, you're not going to get punished for that. It just doesn't make sense. I'm going to share the lecture with everybody. And so, I just want anyone who has questions to be personalized, to feel free to ask me. I'm here. I'm ready to answer any questions. But anyway, let's keep on moving, all right? So let's see. So she just really wants you to remember that first generation and second generation, the whole thing about small children, elderly, the first generation make you sleepy, Benadryl, right? So just familiarize yourselves with the names, but that's where you want to make sure you don't just put somebody on diphenhydramine when they're over 65, right? Fall risk, okay? Sedation, she clearly cares about it a lot. And the reason why you don't get the sedation is due to the lipophobic nature of the second generation. If it's lipophilic, it can cross the blood-brain barrier, but it won't cross the blood-brain barrier in a second generation. So it'll stay systemic and not get into the brain. And this lecture really is easy, by the way. We'll be done with this one really soon. Intranasal, no more than 3 consecutive days. She goes into more detail about this in a second, right here. The whole protracted, the rebound congestion. That goes back to I think this was a question on the exam, the downregulation of alpha adrenergic receptors. A patient comes to you who's been having, clearly have been having having the congestion, and they've been on, and their drug isn't working anymore. The problem is most likely downregulation of the alpha adrenergic receptor, okay? Phenylephrine, which is an alpha-1 agonist, right? It won't work anymore because you don't have any of those alpha-1 receptors anymore, okay? So there's a limit to how long you can use these drugs, or then they start getting useless, okay? Sudafed. Okay, I mean, you see this is stuff that was from your pharm class during your second semester of first year, okay? You kind of have to get used to these by now, all right? That's not going to be my focus in this. If you have trouble with this chart, email me and I'll help you understand it. But for the vast majority of kind of this lecture, we're not going to spend too much time on that. I want to be more time efficient. So please don't think I'm ignoring you if you have trouble with that. Which one? Oh, okay. Yeah, no problem. So she did care about the glaucoma thing. Okay. So that's going to go down to here. Let me see. Does she have a slide on it? I guess I can't see a slide on it. So, I mean, I'll email you guys about that. I don't want to misspeak. I feel like I know what it is, like in terms of meiosis and mydriasis. What makes diabetes and glaucoma worse? Oh, I see. Okay. Let me write that down and I'll email you guys immediately. I don't want to misspeak. Okay. I'm not going to act like I was prepared to answer that question. It does have to do with the beta 2 receptors, I believe. But we'll come back to that. I'll write that down and I'll email you guys, okay? Or you guys can help each other, okay? Alpha 1 and beta. So you guys can help each other in the chat, but I'm going to keep going for the best because it's, I really didn't watch that lecture, so I don't really know what specifics. But when it comes to the steroids, you really want to be able to separate these, right? Systemic is methyl. These are all almost the same. Okay, budesonide and beclomethasone. Those are the ones that are inhaled. Okay, but trimethylone and fluticasone are intranasal, and methyl. When you add methyl in front of the prednisone, it's you just think of systemic. Okay, it's literally IV. Methylprednisolone is literally IV steroids, which is the first line thing that you give to people who have COPD exacerbation. Okay, don't worry about that too much right now. But okay, she has this in red, how the intranasal corticosteroids work. It's literally a memorization type thing. And she goes over this again, first, second generation, which one's intranasal, which one's systemic, which one's, okay. She only wants you to know montelukast for the leukotriene antagonist. Luke is in it. You don't need to miss this question, please. Please don't miss it, okay? Cromolyn, obviously the mechanism of action won't be tested, but just remember, it stabilizes the mast cell. Basically, it prevents it from releasing all that inflammation, right? And it's very limited. It's just in the local area. It's not like in your entire body system, okay? So I'm just trying to hint the things that you could be asked about. Nasty picture is what it is. Talking about the cough reflex. Codeine, I mean, obviously, we've all heard of codeine, addiction and dependence, but the way it works is it blocks that medullary inspiratory center, right? It decreases the amount of breathing you have. So that's why, you can get respiratory depression. That's like similar to how the opiate crisis is causing respiratory depression and killing a lot of people, okay? And dextromethorphan, turns out it actually inhibits the breakdown of serotonin. And so that's why you can get a buildup of that if you have it with like a MAO inhibitor also with it or whatnot. But this is basically her just telling you about the respiratory drugs that can cause that. Guanefacin, literally these people take this and they start coughing up a lot of stuff. Remember how incentive spirometry causes that mucus to be released and it allows them to use their alveoli a lot? This is kind of a similar idea, but it's a drug. It causes them to spit out a lot of that nasty mucus in there. And that's a good thing, okay? Okay. Does anyone have any questions about that lecture other than the whole glaucoma and diabetes thing? Great. Farm of respiratory infections. All right. This is the annoying one. All right. So she has important slides on all of this stuff. And honestly, you have to like ask yourself, what kind, like you need to figure out the risk benefit ratio of, do I really want to review all this stuff and get it right on the exam if it's one question on mechanism of action? And do I want to invest in the future in terms of like this information? Or do I really just want to focus on the now? Okay. I personally don't think it's too difficult. I think topoisomerase is a very unique one for fluoroquinolones. I just remember that for some reason. And then binding diala is for vancomycin. And then beta-lactams prevent cross-linking of the peptidoglycan by binding to the penicillin binding proteins. You don't need to miss those. 30 is amino and tetra. Okay, and 50 is the rest. Okay, like if you're going to get asked about any of the 50S, it's going to be the macrolide or linazolid. It won't be clindamycin and chloramphenicol. Okay, folic acid, sulfon, TMPSMX. Okay, when do we use TMPSMX? When the CD count drops below 200 in a patient who has HIV and you're worried about them getting pneumonia, right? Exactly. That's what we're worried about. Pneumocystis jirovecii. Anyway, let's keep going. And she just keeps talking diala on vancomycin. It seems like she really likes it. Okay, so if you know the mechanism of action, you know the resistance. How does a drug get resistant to vancomycin? It modifies the diala area. Okay, it modifies its penicillin binding proteins because that's what it binds to begin with, right? Modifies the enzyme that it inhibits for sulfonamides. Okay. you have to, like, this is not my decision to make for you. You have to figure out if this is stuff you want to review and get right. Okay. But side effects, I can probably pick out the most likely ones for you. I think she was nice on our exam and she threw red man syndrome. God bless her during our exam. I think she was nice enough to do that for us. Aminoglycosides and vancomycin are both nephro and ototoxic. You need to commit that to memory. Very high yield. Tetracyclines, you have to remember the discoloration of the teeth and the sun fries thing. Tetracyclines, sulfonifieds, fluoroquinolones. That's really high yield. Okay, she would test you on that. Clindamycin, everyone's pretty aware of the C. diff crap about that. No pun intended, C. diff crap. But macrolides, modal agonist, who cares? Prolonged QT is actually something they seem to like nowadays, the macrolides and the fluoroquinolones. But like I said, I think the most important ones I've talked about: photosensitivity, oto and nephrotoxicity, red man syndrome, C. diff. I can't lie to you and not say Stevens-Johnson isn't important, but Q2, I'm just trying to put these in order for you guys, okay? In order of importance. I think, aplastic anemia for chloramphenicol. Try to remember that too. Or gray, like these just all sound the same to me. I don't know why, but I personally, I'll be honest with you guys, I don't benefit whatsoever from the spectrum slides. They overwhelm me personally. And so I would actually, you're not going to get a question that's like, oh, this person has salmonella. What's the spectrum of what drug and do you give them, right? That's not the way. This is a very pneumonia-centric lecture. So honestly, you need to know what drugs cover MRSA, vancomycin, linezolid. Those are the two most important ones. There are others, but those are the two you need to remember. Which ones cover Pseudomonas? You have to know that list, guys. The whole aminoglycosides and fluoroquinolones. You pick one of those, and then you also pick one of the either ceftazidime or cefepime, the two cephalosporins, versus you can also pick Zosyn, which is tazobactam and ticarcillin, I think. I'm trying to remember. And then the carbapenems, right? So I like the way that Dr. Yance really organizes this. That's the way I would go back. That's the most high yield stuff about antibiotics in this lecture. And of course, don't miss this. Don't miss this, okay? Ox, Diclos, Math, Nav. It's easy, remember. I personally did not remember, but because you just have to remember which ones are Pseudomonas, which ones are MRSA. I know you see MRSA for fifth generation. The drug is called ceftaroline. There are doctors that literally don't even know about this drug because it's new. Okay. So, I wouldn't obsess over ceftaroline. I would remember vancomycin and linezolid first for MRSA. Okay. Vancomycin, gram-positive only. Cool. If this is the way that you like it, the way she has it written down, that's good. But a lot of this is review. It's not actually the TMP-SMX for pneumocystis jirovecii. Again. Okay. The respiratory fluoroquinolones are important to know as well. Okay. Like, this isn't new stuff. It's been mentioned in the other lectures. Okay. And now she's just talking about the pathogens. We've already talked about it. Strep pneumo. Okay. Pharyngitis. We already know that you pick amoxicillin. And then you can pick either azithromycin or clindamycin if they have an allergy. Right? But no amoxicillin, guys. No amoxicillin or penicillin for pharyngitis, aka group A strep. Okay. Like I said, you might not even know who writes this question. Just know the information. Okay. Risk of antibiotic resistance. Cool. Guys, I'm worried about MRSA when they're people who are immunocompromised. They have prior antibiotics. That's why I'm worried about MRSA, because they have a risk for antibiotic resistance. Methicillin resistant Staph aureus. Okay. Connect the PowerPoints. Okay, she's still talking about the similar stuff, right? Guys, let me ask you a second order question this time. A patient comes to me who had an infection, a viral infection, and 2 weeks later, they had felt better, but then they got it again. What is the most likely drug that I'm going to put them on? I want to see more responses. First of all, we know we're worried about what? I asked you that question already. No problem. A patient had a viral infection 2 weeks ago, and now they get a bacterial infection. We're worried about Staph aureus. What drug do you most likely put them on? Exactly. That's how you have to think for this exam. Okay? Combine details and apply them on a question. That's what I'm trying to hint at for you. That's how it works. Okay? Get that down. You're going to be doctors, right? So you want to be good at this stuff. You want to train yourself into thinking about this stuff. Okay? So, anyway, this common theme of 65-year-old, chronic diseases, smoking and alcohol abuse, okay? Walking pneumonia from mycoplasma. They're literally just repeating this over and over and over again, okay? Strep pneumo is literally on the top of the list for almost every single one, okay? And honestly, I personally like to go back to what Dr. Jans put on his lecture, okay? If I need Pseudomonas, I'm going to put them on what? I'm going to be considering either the cefepime or ceftazidime, right? Which is the beta-lactam that covers anti-Pseudomonas and pneumococcal. Those are the two. That's what you pick most likely, okay? Or a carbapenem, and then you either add it to, like, I don't like the way, personally, all respect to Dr. Weaver, I love her, but I would stick to that basic, okay? Stick to that basic. If person's outpatient, you give them azithromycin or I would think of macrolide, okay? If they go inside of the hospital, I'm worried now about some more important things, okay? I'm probably going to put them on a fluoroquinolone, or I'm going to add this double regimen, okay? A fluoroquinolone actually covers pretty much what a beta-lactam and a macrolide cover together, okay? What azithromycin and another beta-lactam like ceftriaxone or whatever, those two probably cover close to what a respiratory fluoroquinolone covers. I'm just trying to add some concepts that she has in here. But stick to that basic, guys. Stick to the basic. I personally did not benefit from this slide very much. Okay. I would go back and see what she does with, she has questions at the end of this PowerPoint slide. Okay. 1 second. I'm really just going by what she flags as really important, by the way. She's really, really reliable in that way. Okay. It would be a blessing if you guys got a question from anything other than that and you got the Tamiflu question. Okay. You need to know the neuraminidase inhibitor. Okay. And it has to be within the time. Okay. Within 72 hours. Okay. You give them Tamiflu, influenza. What's the mechanism of action of a patient who comes in and they've been feeling really sick recently? Okay. I'm going to put them on Tamiflu. The mechanism of action is neuraminidase inhibitor. Okay. Cystic fibrosis, Pseudomonas is back, guys. It's not leaving us. Okay. You have to know the medications that cover it. Okay. Give 2 anti-pseudomodal agents. All right. In the cases. Okay. I'm not going to go over the cases because she goes over these, right? So go over this. If you feel like you just need more information from the way that Dr. Weaver goes over things, after this PowerPoint slide, after we've learned all this stuff, I want you to feel more comfortable looking at the cases now. You see what I'm saying? Go over the cases. It doesn't hurt, you know? But you need to know yourself. But that's pretty much it. Like, I mean, she goes over all this stuff. Okay, she has an important slide here. So definitely probably go back over the slide and see what she says in there. It should make a lot more sense if you were struggling with it beforehand. I would literally skip to these PowerPoint slides. Skip to these. Who cares about this stuff? Skip to this point and listen to what she says. That'll put you in the mind of her mind, right? I'm just seeing if she's just telling you all the drugs that cover this stuff. Okay. Any questions about how to approach if it's an aspiration-caused pneumonia? Should we choose moxifloxacin to cover the anaerobe, even if we weren't told it's an anaerobe causing the pneumonia? I think when I see, you can just give them Zosyn, to be honest. For people, what I saw based on the other PowerPoint slides was that you can give people who have aspiration pneumonia, you can just give them ticarcillin or piperacillin tazobactam combination. That's first line, okay? And then you want to start thinking about some of the other drugs like metronidazole and clindamycin. Where Moxie kind of fits into that is not something I'm too aware of. I'll also write that down and answer that question for you, but I don't think I can answer that knowledgeably right now. Okay, so right now what I have written down is the glaucoma and diabetes, and I'm going to write that down as well, and I'll send out an email explaining that. Is that cool, Vlad? Cool, no problem. All right, so we did respiratory infections. We finished all the Dr. Weaver thing. The things that we have left are really the micro, and we have pathology of head and neck and tuberculosis. In my opinion, I think what we should do is go ahead and talk about, I'm going to tell you what's high yield. Oh, I do see the pulmonary function testing PowerPoint that Dr. Wisnoff did. He never lectured us, actually, by the way. That's a different lecture. I've never had that lecture. But I did look over it, and it looked very self-explanatory from the outside. It looked like he had questions and explained it, and it's stuff that you've been over before. It had things like the PFTs, and you kind of have to know all the stuff again about like if your FEV1, FVC ratio, all that crap, right? I want to know from you guys' opinions. Was Dr. Wisnoff's lecture relatively straightforward in a way? See, I didn't even listen to it, but based on his PowerPoint, it looks very straightforward. Okay? Now, for anybody who doesn't think it's straightforward, I'm not ignoring you. Please email me. If you have a question, I would be glad to go over that stuff with you if you struggle with it. Please email me. Awesome. Dr. Wisnoff is freaking awesome, honestly. He's a boss. I like him. Anyway, so please email me. If there's something that the majority of people feel like is straightforward, that doesn't mean I won't go over it with you. Email me, or stick around and tell me. Privately message me and that, no, it wasn't straightforward to me. Please help me out. I don't mind, okay? But anyway, let's keep going. What I'm going to do, the plan for the rest of this session is going to be the following. What we'll do is I want to tell you guys what I remember being high yield from the head and neck lecture from Dr. Wang, okay? Because I know he's pretty dense with his information. I'll tell you what you'll most likely get some questions about from the TB lecture from Dr. Zirin. I won't act like I'm a baller at parasitology. I literally hate parasitology so much. I think the best approach for that is actually going to be me going over it and sending an email with the things that are most important from that lecture. I will leave that to last. I know he likes Loa a lot, but I personally thought I approached that with the least urgency when I was in your position, to be honest. And I have input from that year and the year after about what he liked to test. So I'll share that with you guys. And I'll leave Dr. Colley's for the last. If anyone wants to stick around for that one, I'll do that. But I'm going to go ahead and when you say head and neck, are you talking tumors of the upper respiratory tract? Let me see if that's what he labeled it as. I think you're right. I think that's what he labeled it as. Yeah. He basically, the name of the... Yeah. No, so the thing is that I actually don't know how long it takes for it to come out, but it says that it goes straight to my computer after I end the session. So as soon as I see it, I'll send that out. I'm not too sure. I'm pretty sure I have to like upload it on YouTube or something, and like I'll put it as unlisted so that anyone with a what is it called, a link can watch it, and maybe I can put some timestamps to kind of help you guys out about where we started what. But I can't promise that yet. But anyway, is that cool with you guys? What we're gonna do is I'm gonna do Dr. Wang's lecture, then Dr. Zirin. And then I'm going to leave Dr. Colley for last. I'm not going to actually go over Dr. Kunagalis's lecture in here. Because I actually don't know. I'm going to look at the PowerPoint and I'll pick out what I know he's really good at, what he really likes to talk about. But I don't actually think it would be very important. I'll probably talk about it at the very end, but for now, you know, I'm going to do the most important things first. And I think Dr. Wang's is something that people commonly get kind of overwhelmed by. So let me go ahead and pull that up. Where is that lecture? Sorry, 1 second, everyone. Okay, got it. Can you guys see it? Great. All right. So, wouldn't worry about this stuff right now. This is just, sorry, my throat is, guys, give me 1 second. I'm going to run downstairs and grab a bottle of water. I think one of my family members sprayed like some sort of perfume and it's actually irritating my throat a lot. So I'll literally give me like less than a minute to go get a water bottle. All right, I'm back. Sorry about that, guys. Okay. So, all right. Notable things about the nasopharyngeal angiofibroma is exactly what he has outlined. If you're going to get a question on it, it's most likely going to be the androgen receptor idea. Okay. And he emphasizes it again right here. Immunochemistry for the androgen receptor. Nasopharyngeal angiofibroma. Now, excuse me. Histology wise, I know no one, most people don't like histology too much, but this is actually kind of unique. It's not something that I would really freak out about. Usually blood vessels are not shaped this way. Okay. Usually blood vessels are a lot more uniform than that. You see kind of a jagged type appearance for blood vessels. And that's, you know, if you get that picture, it's a gimme. You're going to pick androgen receptor positive. Okay. If you're not getting a first order question about what is it, angiofibroma. Okay. Schneider. Okay, yeah. I'm not even gonna try. Schneiderian, whatever. HPV-6 nasal septal tumor. Okay, if you're gonna get a question about this, it's gonna come down to the whole exophytic versus endophytic. Okay, if it's on the septum, which is the medial part of your nose, right? It's gonna be an exophytic type histology. If it's on the lateral wall of the nose, right, like what you can press on from the outside, it's going to be inverted, inward, right? So let's look at some histology there, okay? So this is just from the outside, but you can't see, you need to look at the actual histology to tell what it looks like, right? Endophytic, let's compare and contrast. When I see exophytic, I see it like popping out, right? Just like he's saying, like it just popping out papilloma, right? When you see here, it's a lot more reserved, right? So what would I do here? I would look for the vignette that talks about a mass on a mass that is starting on the lateral part of the nose. What is the most likely histology? It's an inverted papilloma. Or what is the most likely, not immunochemistry, but what is the most likely risk factor or whatnot? HPV 611, right? Okay. Oncocytic papilloma. Why do I feel like he put this on the exam? The micro abscesses. This is like, for some reason, this is kind of it's jogging my memory big time. All right. Put a star here. I really feel it. I'm really feeling that this is probably a question. I think it was just written as intraepithelial mucin-filled cyst and microabscesses, or microabscesses was there. You're going to be picking the oncocytic papilloma or the Schneiderian papilloma. This is a type of so Schneiderian oncocytic papilloma, basically. Okay. So know that. Here, what you need to do is that you see it's a neuroblastoma. Okay, so anything that has neuroblastoma in it, you know that the immunochemistry is going to be positive for the neuroendocrine markers, which are what? Synaptophysin. Let me see, where is that? Synaptophysin and chromogranin. Okay, those are the two that tell you you're dealing with a neuroblastoma or a neuroendocrine tumor. Okay, so if you see synaptophysin and chromogranin, you're going to be thinking of the neuroendocrine tumor, the neuroblastoma. Okay, the one in the nose. Okay, so it's going to be a mass that can invade the interior cranial fossa. That's just an example. It doesn't always do that, but clearly, if it's invading, it's malignant. So that's kind of the way I would summarize this. Okay, you would have to know these markers. Those would be heavily tested. And honestly, if you remember, here's a way I remember this. Actually, you're going to have a lecture later on this week where you're going to be learning about the different lung cancers, okay? You're going to have squamous cell carcinoma. You're going to have small cell carcinoma. Don't worry about that right now. But let me make your life easy, okay? Small cell carcinoma is actually a neuroendocrine tumor of the lung, okay? So I'm mentioning this now. It actually literally looks like a bunch of blue cells that are scattered around the entire cell parenchyma in that cancer, okay? So when you look here, you can actually see these just literally look like a bunch of small little cells, blue, purplish cells that are just scattered all over the place. That is actually very characteristic of a neuroendocrine tumor, okay? So synaptophysin, chromogranin. That's probably as crazy as this lecture is going to get. Now, the nut midline carcinoma, why do I think this is going to be on your exam? I remember that Dr. What's his name? Dr. Wang was basically telling us during his class that he had a friend that actually I think he got the nut midline carcinoma. I believe. Okay. I think that's what happened. And I'm trying to remember how he tested it. He may have put a picture. It was either that or it was the nasopharyngeal carcinoma. When I was first looking through this PowerPoint, I was thinking it was going to be the nut midline carcinoma that he put on the exam, but he really just doesn't have enough information out here. Like, I really don't see enough information. Okay. So, I mean, undifferent, separated by desmoplastic stroma, I think it might have been actually the nasopharyngeal carcinoma. And this is very high yield for your board exams. Okay. They just love it. If they're going to pick a cancer that's in the nose or anything, it's this. Okay. And it's the EBV connection that's very important. Okay. He will probably put this one on the exam. He'll probably put this one. So I'm sorry, I keep on saying that. I think this is it, actually. Okay. And so you have to know the risk factors. You have to know that it's associated with EBV and it's a cancer of the nose. Okay. Not just the nose, but behind the nose as it connects to the throat in the pharynx region. Okay. Know that. Okay. Usually people in Asia, so Southeast Asia is usually the specific one. China, the China South Asian region, plus EBV or plus these risk factors, and they get cancer, you know that it's associated with EBV. Okay. And I guess he might like the fact that the pathogenesis is the loss of heterozygosity, LOH, at 9p and 3p. Okay. I'm just giving you the small things that I would throw in there if I were you. Okay. I mean, really, really not. These symptoms are really not going to get you the answer right. But he's stressing EBV. Don't miss that. Don't miss that. Please don't. Okay. Cool. Radiation. All right. So a singer or heavy smoker, anything that causes some sort of inflammatory process on the vocal cords, you can get a polyp there. Kind of makes sense. Like you irritate it, grows a polyp, whatever, you know. Um, and there's really not much more to say about that, guys. Like honestly, it's really not much more to say about that. And you can see that HPV is back now in terms of associations. So if I were you, the way I would approach that, honestly, like a squamous papilloma, you just have to know it's associated with HPV, okay? And it's a warty, and you can look at it. It almost looks, it's weird. It almost looks microscopically the way it looks grossly, okay? Like the shape, if I looked at that, I would know it was a papilloma, okay? Fibrovascular core, the blood vessels, you see those? Okay. Cool. I mean, I'm not really. The only reason I would get excited about this is the E6, E7. Like, it's almost like DCOM will use any moment to bring back testing your understanding of E6 and E7 mutations, causing squamous from HPV, causing a squamous cancer. Okay, so bear that in mind as you approach this lecture. Now, what I'm actually excited to get to is these. Okay, these can be you're getting a question on one of these. 100%. Okay. And I personally think it's going to end up being the thyroglossal duct cyst. Okay. I actually saw one of these on Friday in an endocrine clinic. Okay. I mean, it's really just based on location, guys. Like a midline painless mass. Okay. Thyroglossal duct cyst. Where it gets kind of awkward is when you compare the branchial pouch, cleft, and cyst. Okay, group these in your head. You have to group. Okay, squamous epithelium is the cleft, respiratory is the pouch, and the branchial cyst is its own. Okay, the branchial cyst, here's the way I would group these. I would group these together like he has. Okay, but you need to remember that the thyroglossal duct cyst and the branchial cleft cyst are the two that you're going to keep together. Okay, there's no cyst here. Okay, branchial cleft and branchial pouch, you're thinking of squamous and respiratory, and it's usually in the anterior lateral side of the neck. But when it comes to the cysts, which are the branchial cyst and the thyroglossal duct cyst, the branchial cyst is in the lateral region, comes from the second branchial cleft, which is, like I said, this is where you really have to I think it's going to be a first order diagnosis question, to be honest with you. But if you end up having extra time, go ahead and memorize why it happens. But yeah, so branchial cyst, lateral part, thyroglossal duct cyst in the midline. Okay, so I would say your three questions are going to be one of these, either the petch, cleft, or cyst. One of those. Okay, don't forget thyroglossal. You have to know one of those. I wouldn't say you're going to get a vocal cord question. If he's nice to you, he's going to give you the singer. Okay, if he's nice to you. I think you're getting a question about nasopharyngeal carcinoma. Okay, diagnosing it with epidemiology. And I think the other question is going to most likely be, I think it's going to be, it's a toss-up between angiofibroma and the Schneiderian papilloma. Okay, don't forget exo and endophytic. Okay, that's the way I would characterize these if I were you. Okay. And I'm sorry that there's no concepts. Like, it sucks. Like, I wish I could be way more helpful, but that's the nature of the material, guys. Okay. So if you have questions about certain things that I haven't touched, I'm trying to just guide your memorization. Okay. I almost kind of I feel useless sort of sometimes with tutoring this particular block because it's so memorization heavy. So please feel free to ask me if there's stuff that I definitely did not do this perfectly. So feel free to reach out to me. I'm more than happy to help you out. And let's look at TB now. The highlight is going to be found in the, let me pull it up first. And remember, this is actually recorded. So, if you have to run and I've been taking forever, feel free to do that. I'm going to keep going like it's a full house either way. But please ask questions. Please ask questions. If you don't know something, if you feel like I'm not tackling it right, please do so. I know I'm annoying you guys by saying that 500 times, but okay. I think this is it. Okay. So your questions from this lecture are going to probably be, okay. First of all, you're going to probably get a question about knowing that you test for induration. When you read it, you look at induration, not erythema. Induration, right? The induration, not the erythema. Who cares about erythema in this case, okay? If you don't pick induration, you will lose this question, okay? Now, this crap. I don't like the way she presents it, okay? I like this chart right here from Online MedEd, okay? This is the gold standard material for the gold standard information for your clinical years, 3rd and 4th year for step 2. I love this, okay, because it really just summarizes it perfectly, okay? If you are a normal person who hasn't had any weird exposures and is just living in the real world, you're a medical student that hasn't even gone on to the clinical years, and you do a TB skin test and it's 10 millimeters, you're fine, okay? But if you do it and it's 20, then we got to investigate more, okay? We have to do a chest x-ray, all right? We have to report it, okay? But these make sense. The worst, right? The threshold of 5 millimeters is someone with HIV or AIDS, an organ transplant, they're on steroids, or they've been contacted by TB. Wow, that was incredibly different than anything. No, it makes sense, right? Close contacts of TB. And then in the middle is the healthcare provider, someone who's homeless or incarcerated in close quarters or travel to an endemic area. We put 10 millimeters on that. But unless you're severely immunocompromised, if you're not immunocompromised and you're not normal, you're in the 10 millimeter range, okay? I put it again. Like, she has a bunch of these lists. This is the way I would think about it, okay? This is one question for sure. She wants to know if you know the millimeters and how to apply it to a patient, okay? So that's the next step, obviously. Not too crazy. Just showing you some pictures of the granulomas. Remember, when I'm worried about TB, night sweats, weight loss, fever, weight loss, night sweats. You add in hemoptysis, icing on the cake. Got the diagnosis most likely. But fever, night sweats, and weight loss is just constitutional symptom craziness, and you're worried about TB. Okay. And you may get a question about what test is the best for TB, and you're gonna be picking the quantiferon TB. This is a rapid diagnosis, but this is a very, very gold standardy. This is very gold standardy for this, okay? Go back to what she says on this slide. That will get you the question right on the exam, okay? And you have to know the general idea, guys, where the person who primarily gets TB, when they get it initially, they got an exposure, they don't know it. They don't actually get symptoms most of the time. When do people get the fever, night sweats, hemoptysis, and weight loss? They get it when there's secondary activation of TB. You get inflammation and you get a problem. You get a major problem. That's where you get the cavitation and you get the problems, okay? I want you to kind of that's how you make sense of this page. You might get a pathogenesis question, okay? So it goes latent after primary. It either goes latent or it progresses into primary TB and disseminates and really screws over the patient. Okay, it either goes latent or it disseminates into a primary TB that you actually see. Okay, if it disseminates, you see it because it starts affecting their liver enzymes go up, whatever. You have insults to different organs, but most of the time it goes latent and then it gets reactivated when you're immunocompromised or something happens that makes it feel like it's a good time, I guess, for reactivation. And again, Ghosn complex is back. When does it become a complex? When it affects the lymph node as well, okay? Cool. And there's a heavy emphasis on the fact that the primary disease, if you do an X-ray to somebody who doesn't even know they got, you do. Let me give you an image of this, a story of it. Somebody comes to you, a med student comes up to you, and he says, "Hey, I got to get my TB skin test. I'm really annoyed. My school's gonna kick me out of the school if I don't do it." Okay, all right, you go do it, and then you get 20 millimeter in duration. Okay, and then the healthcare person's like, "Oh my God, this sucks. Let's do it. I have to report this and I have to do an X-ray." They do an X-ray and they see this. Okay, and the person might be normal. We know at this point, the reason why this is happening is that the primary disease actually has a predilection for the upper lower lobe or the lower upper lobe. What's the best way to know this? Best way to memorize this? The middle lobe. The middle area of the lung is the best way to remember that. Who cares about upper, lower, and lower upper? Screw that, dude. Just remember the middle part of the lung, okay? The middle part to the lower. Secondary disease is where it gets activated at the top, okay? Right here. Right here. All right? There's the cavity, okay? You need to know that. And if you get lymphadenopathy, I don't think you'll have to recognize that on an X-ray, okay? And this is miliary, just by seeing this disseminated ... everywhere, okay? Cool. TB is diagnosed, report it to health department, and start treatment. Treatment is usually, you're going to probably start these people on isoniazid by itself, actually, if they have a negative chest X-ray, right? If they have a negative chest X-ray, but they have a positive TB test, they're probably going to be put on isoniazid, okay? If they get a positive chest X-ray and then you do the quantiferon and it's negative, well, you probably will still start them on isoniazid, okay? Now, but a person who has hemoptysis, weight loss, all these I almost said constipated, all these constitutional symptoms, you're actually going to start RIPE therapy, okay? Rifampin, isoniazid, pyrazinamide, and ethambutol, okay? That's for particularly secondary TB after it's been reactivated and they have symptoms, okay? More special circumstances and preventing it. Guys, I think I remember a question from the exam. For me, it's more so like I just remember this being important, okay? The N95 mask. I don't know why. I don't know why. I just remember that, okay? I remember that being important. It's been 2 years, so I cannot be accused of telling you what's on the exam. I have an impaired memory of what this exam was like, okay? What I'm telling you is what I think is important, okay? And I'm trying to remind you, I'm putting a big star next to N95, okay? Please remember that, okay? Masks. It decreases problems, okay? Anyone have any questions about that lecture? Is everyone still with me? Let me get an okay or a yes or something, just so I know everyone's alive. Awesome. Sweet. Just had to check up on you guys. This stuff gets really boring, I know. Anyway, let's go. I'm going to go to Kali now. Dr. Kali. I trust that you guys can see this. Just a few people just put it in the chat, so I know I don't just start without you seeing it. Awesome. Okay. So you're going to see that we've really gone over a lot of the stuff. Okay. We really have gone over a lot of the stuff. All right. He has this in the objectives. Compare and contrast professional versus secondary. Okay. It's really not that hard, but like, just look at it. Make sense of it. A professional can infect a healthy. So what do you consider to be healthy? What do you expect to be a quality of a professional invader? They should be able to disrupt the normal histology, the normal structures of the lung. They adhere to normal mucosa. They interfere with the cilia. They won't get destroyed by the macrophage, the resident macrophage of the lung. Okay, and then they start destroying local tissue. That's what causes the symptoms. But these are the things that you should be thinking of as, the keys for a professional. Okay. Secondary, take advantage of a person who has immunocompromisation. Okay. HIV, greater than 65, renal or hepatic disease, cystic fibrosis, pseudomonas, right? Someone who has the flu recently and they get Staph aureus, right? Staph aureus is going to freaking use, I'm saying that 5 billion times, right? So anyway, I really don't know what he talked about on the slide. I don't actually think it's necessarily important. This is more so just to kind of make you think like a doctor, but right now you just want to get through the system. So anyway, pediatric antibiotics, less than 5, greater than 5, cool. He's just giving you an image of otitis media at this point, right? Use this to create your own vignette in your head. And guess what is the most common cause of it? Strep pneumo. Warxilla is like the second or third most common cause. It's never the first common cause of anything. Strep pneumo is the most common cause. Okay? Please know this. Difference between chronic and serous. Serous is actually like, you literally have like this buildup. You have this chronic infiltrate basically that, so it says thick non-purulent secretions in the middle ear. And they can both cause hearing loss, both the chronic and so that's why you want to treat an acute otitis media ASAP. Okay. So, I mean, I'm trying to remember how these questions were asked. I mean, less than 3 months, you're worried about strep pneumo mostly. More than 3 months, you're still worried about strep pneumo, but you add in Haemophilus doesn't come in until after 3 months. Okay. So that's his point there. Drainage may be required, inclusion. Cool. I mean, he's just giving you a bunch of like, basically you're giving these people amoxicillin. Okay. Sinusitis, other causes include allergies, air pollution, structural. Cool. We've talked about this. Okay. He just has it. He's just saying that's mostly viral, just like everything. A picture of it, right? Drainage. There's this increased signal in their literal cheekbone area, their maxillary sinus. Please just don't ever pick Moraxilla as the answer for the most part. Like, strep pneumo. I mean, it just continues to go on, dude. Hallmark of bacterial sinusitis. I mean, this is important actually. The fact that this person's been having these symptoms for more than 10 days is actually like textbook sinusitis. So look for somebody who hasn't had these symptoms resolved. Their congestion, their pain, their facial pain, right? Their drainage. This hasn't resolved for 10 days. Usually a viral will resolve in under 10 days, okay? But if these people come to you and they're like, dude, I'm starting to have difficulty with these symptoms and it's been more than 10 days, you're worried about sinusitis and a bacterial cause more so, okay? Probably going to put these people on amoxicillin. Empiric treatment for an uncomplicated is amoxicillin. If the amoxicillin doesn't do the job, you add in clavulanate to the amoxicillin, okay? So anyway, these are the fungal ones that cause sinusitis in a patient, particularly diabetes for Mucor. Don't really care. That's just boards, I guess. Fever, all this is being belabored, guys. Major, minor criteria, cool. You have to be aware of a picture of a sinusitis patient. Okay. Rhinitis, variable, could or could not have a fever. Most of the time, you're just looking for edema of the mucosa, runny nose, just annoying symptoms for the most part. Okay. There's pharyngitis again. I mean, the point here is that like these are like particular RSV here is what you're worried about in pharyngitis for a younger kid. But usually you're going to be worried about group A strep in this subgroup of people, the 5 to 15. I mean, literally seeing the same thing over and over again, guys. Like this is you need to know, you have to know the stridor, the croup, the barking cough. These are buzzwords. Excuse me. Buzzwords for this material. Okay. Like group it. Spend time and group this information. I can't memorize it for you. You know what's best for you in memorizing. If you need suggestions, reach out to me. I got you. There's still a bunch of time before your exam. But I mean, this is the hallmark here, coarse bubbly rhonchi, okay? I am not claiming to be like a baller at the micro of knowing what's going to be asked or anything like that. Dr. Colley is variable with his information, okay? But usually his questions are very straightforward. He's not trying to trick you. He's trying to trick the people who don't look at his lecture. That's what he does. Like that's what matters. And it's most professors. More pneumonia. Talked about this a billion times. Walking pneumonia. We belabored it. We don't have to keep belaboring it, right? CD counts, right? Someone's super immunocompromised. Post-viral infection, Staph aureus. IV. You need to have these down, okay? The ones most important: alcoholism, being Klebsiella, impaired glottic reflexes, IV drug abuse for Staph aureus, post-viral infection, Staph aureus, no, these are additions. These are, yeah. I recognize how little of you, like how not useful I was when I explained this stuff, but we've really gone over it, guys. And you just have to keep on going over this stuff over and over and over and over again. That's just the way that you do it. So, I mean, for the most part, that's pretty much all the lectures that I've been up to this point. I didn't go over Dr. Kunagalis, whatever. I think I'm actually going to go ahead and just go quickly through that lecture and just, if something appeals to my memory, I'll let you know. But you know just as well as I do that it's straight up memorization. Okay. Did Dr. K stick to his objectives? Because it's very narrow objectives. Dr. K, no problem. No problem. You have a good one, Caleb. No problem, Jordan. You guys have a good one. All right, I'm going to go ahead and share. No problem, Evan. All right. No problem. No problem. Hope the best for you guys. Please email me. Oh, and anyone who's interested in like the renal and you're not on the list, go ahead and email me and let me know you're interested in it. But I'm planning on doing renal in the next few days. I just kind of have to organize it a little bit. I have a PowerPoint ready for that. That's much more conceptual than this stuff. It has a good number memorization, but I can group it much better. But as you can see, the nature of the material for this stuff is the way that it is. Anyway, can you guys see this? Can you guys go ahead and can you guys see this PowerPoint? All right. Slideshow. Okay. Based on my memory, okay, let's see. Sorry, guys. I'm just trying to jog my memory at the moment. This is coming back to me. I think this is an important one. And let me see what's actually important about it specifically. I think it's knowing that a risk factor is walking barefoot and it penetrating the soles of your feet and knowing the pathway. Just kind of knowing that like it goes from the foot to the blood, getting an idea of, I don't think it was a picture. I don't remember a picture being the case. Man, that's the same thing with strongyloides too. I'm trying to remember, guys. Loeffler syndrome. I feel like he made a big deal out of it, and I don't know if he actually put it on the exam, but that would have been a really easy question for him to put on there, the eosinophilic pneumonia. But let me find Loa Loa. This is on your exam. This is on your exam. He loves it. He loves Loa Loa. Okay. And so I would go back to what he says on the slides about it. It's very important. It says new because that was not on the PowerPoint slide when he taught it to us. I don't remember him doing, no, I don't think echinococcus was on there, but that's just knowing the fact that there's a cyst in the liver. That's the most important thing about echinococcus. Okay. I like I said, I absolutely hate parasitology, and I'm trying to remember what he thought was important. I would be a liar if I told you that I would memorize all this stuff if I was in your position. I would have focused on all the other material, and then I would have added in this material. Okay. So what I would do is, okay, useful for pinworm, hookworm, Ascarides. Which one is only a few? Okay, diethyl alters surface structure, increases susceptibility, acts by blocking microtubule synthesis, increases cell membrane calcium permeability, inhibits microtubule synthesis. Okay. You're getting a question for sure on knowing what drug to pick based on its mechanism of action. So he may want you to actually, he might give you the drug and tell you what the mechanism of action is, ask you for it, or he'll actually tell you, okay, the patient has hookworm, and what drug can you give them? What's the mechanism of action of the drug that you would give them? Okay. I'm just trying to give you guys ideas of how we could ask things, but I know for sure you're going to get a farm question. You're getting a Loa Loa question about diagnosis. And honestly, that third question is a toss-up, guys. I'll have to think deeper about what I think the question was. It could have been could have been Ascaris, it could have been Strongyloides. I think this one's important because I think it has a connection to, does he have it in there? Pigs? I think eating pork, uncooked pork. Yeah, he doesn't have it in there. I'm sorry, guys. It's not. I know that this wasn't the most useful part of the lecture, but of the session. But sorry, I'm not trying to give you guys also a seizure by switching slides. But yeah, that's. I don't want to give you wrong information. I don't want to give you wrong information. So if you guys find a way to kind of like organize the most high yield information for this, help each other out. Help each other out. Like this is just like this PowerPoint is not going to make or break anybody. It's just nice to have extra points if you feel like you have a good way of breaking things down. But otherwise, that's pretty much it from my side. If anyone has any questions, please ask them right now. And if you don't have any right now, please email me. I'm completely open to answering them. But yeah, guys, no problem. No problem. I'm really happy that was helpful. You guys have a good night. No problem. No problem.